Hello, a very warm welcome to all of you to Pfizer Anti-Microbial Resistance Summit 2022, organized by ISW Council as a knowledge partner with Americares India Foundation and Pfizer India. I'm Anisha Nayadhavan, and on behalf of ISW Council, I once again welcome you to this very crucial expert discussion around the challenges in infection prevention and control and the role of antibiotics in achieving this. The world has already seen the impact of COVID-19 and the way it toppled health infrastructure the world over. The novelty and the sheer scale of the situation has left healthcare professionals as well as other stakeholders grappling with an unprecedented situation. All of us have been reminded of and have finally realized the significance of good health and well-being because of the pandemic. The pandemic has also worsened the threat of antimicrobial resistance, AMR, due to indiscriminate use of antibiotics for symptomatic treatment of COVID-19. Key discussions around infection, prevention, and control cannot be complete without taking into consideration the challenges posed by AMR. The need of VR is to identify the problem and come up with concerted and coordinated efforts to defeat it. Without further ado, let's begin this session. I would like to invite Mr. Sharat Goswami, Senior Director, Emerging Markets, Policy and Public Affairs, Pfizer, to give us an overview of Pfizer's CSR work on AMR in India. Over to you, Mr. Goswami.
Thank you, Anisha. Thank you to all the participants who have joined the event today. Your presence here only shows that AMR is an issue that is of importance to you and that you are aware of the significance of this challenge and that you are choosing to invest some of your time in understanding it better and contributing towards alleviating it as well. So I want to thank you for your interest in this subject. Very good afternoon.
I'm sorry to interrupt you, but request you to please turn your video on. We can hear you, but not see your video.
Oh, okay. My video was on. Can you see me now?
Yes, we can see you now. Please go ahead.
Okay. All right. So again, with a note of thank you, I also want to acknowledge the presence of our guests, our chief guest, Ms. K. Shelja, teacher. We know her from the sterling work that she has done as the former health minister of the government of Kerala. We've had opportunities to interact with her, and we know that she is passionate about this subject. There's a lot of work that she has done in this area. So we're very grateful to you, ma'am, for your time. I also extend a very warm welcome to Dr. Atul Goyal, who is the Director General of Health Services in the Government of India and the Ministry of Health. Dr. Goyal, I met you just a few days ago, and you spoke about how AMR is a subject that, as a clinician, you are very well aware of and are also concerned about. And so your presence here also shows your commitment towards contributing towards alleviating the burden of AMR. So we thank you for your time. All of you
Mr. Goswami, I'm so sorry to disturb you again, but I think we've again lost your video. Could you please turn it on? Yes, we can see you now.
I don't know why this keeps getting switched off, but give me a second. Maybe there is some setting I need to fix. Sure. So all of us are aware of the seriousness of the issue, and we are all here to address it. From Pfizer's point of view, as one of the leading antimicrobial companies, we invest very deeply in the discovery and commercialization of antimicrobial agents. AMR is a threat that we are well aware of, and it's a threat that we work very hard to bring in good practices to counter. Many of you perhaps know, many of you may not, but Pfizer was the first company to mass produce penicillin way back in 1941. And since then, our portfolio does comprise a number of antimicrobial, antibacterial, and antifungal agents, many of which are targeted for acute and very difficult to treat infections, predominantly in ICU settings. And as we interact with physicians, we are all but aware of how dire the situation is, where very quickly and at very rapid pace, we are losing many of our established antimicrobial agents. And we are left with no choice but to rely on only a few that are still effective. The pipelines are not so rich. It takes a lot of effort to discover new agents. And so it's critical that we conserve what we have and we are judicious with what we have. Because of our focus in this area, there's a lot of work that we do in the area of corporate responsibility as well. On AMR, I'm very proud to first and foremost note our partnership with the ICMR. I'm grateful to have Dr. Kamini Walia from ICMR join this conference today. She is a terrific leader and a thought leader in the area of infection prevention and control and curbing AMR. And with ICMR, we have a wonderful project, a partnership that's already underway. Many of you would have seen a public service campaign that we had launched some time back, and we had said, AMR, aao milkar roke. And we were aiming to generate public awareness around this issue. But this partnership is also about creating a public-private kind of mechanism through which currently 11 nodal hospitals are working towards the expansion of AMSP and IPC programs in about 90 nursing homes and district hospitals. Dr. Kamini will share more details about the work that ICMR is doing. Wonderful, sterling work in this area. About a year ago, we also partnered with the Americares India Foundation to launch the Parivartan program. I know the Americares team will share more details in the panel, but our objective through the Parivartan program was to say, how is it that we can demonstrate in small to mid-sized hospitals and nursing homes that if you invest in the area of AMR, there can be tangible improvements you can have in many of the key parameters that determine the success of a hospital. Things like how much of hospital-acquired infections do you have and how much of that can you control? What is the pace at which you can actually turn around your beds just because you have now good practices on infection prevention and control? So the whole goal of the Parivartan program was to demonstrate to hospital administrators and hospital owners that it makes a lot of sense to invest in infection prevention and control. So that's the program that's currently underway in about 11 mid-sized hospitals across 7 states. And we are hoping to demonstrate findings that show that small interventions like training, like infrastructure fixes, can go a long way in curbing, preventing infections, reducing the use of antibiotics, which is a very important parameter, reducing the extent of hospital-acquired infections, and improving overall outcomes from hospitals. So that's a wonderful project that's currently underway, and we'll soon enough be sharing some outcomes from that project. But what we are here for today is the second project that we have with Americares, which is called the Open Amr Project. We know that India has a very large segment of nursing staff, who are paramedical staff who work across various sizes of hospitals. And our nursing staff plays such a critical role in ensuring that patients receive the care that they need. And they are also really important stakeholders in all aspects of infection prevention and control. Our whole endeavor through the Open AMR program is to build an online and digital platform through which nurses, nursing staff, paramedical staff across the country, across hospitals, government, private, small, big, can all enroll into a program, which is an online digital learning program. And at the end of that program, which covers various aspects of infection prevention and control, can get certified as having been trained in global IPC best practices. Not only does the certification provide value, to our nursing colleagues, but the training itself, importantly, refreshes the learning on what are the good practices to follow, what are the do's and don'ts, and then for our nursing staff to also then be proponents amongst their stakeholders, amongst their hospitals on some of these good practices that they have picked up through this course. So we are very, very grateful to Americares for having created this entire module. What's interesting is that this will be a multilingual module. So we will over time have almost all the regional languages through which this module can be conveyed. And I know that America's team will give more details on this as they make their presentation. With that, I again thank all of you for your participation today. As we have said in our campaign earlier, AMR आओ मिलकर रोकें. We all have a role to play. We all have a responsibility. This is the pandemic of our times. And this is a pandemic that we all have to get together and do our bit to make sure that we alleviate, we curb, and we make these life-saving drugs continue to be effective, last longer, preserve life. That's what we are all here for. With that, I want to thank you, and I turn this back to you.
Thank you so much, Mr. Goswami, for your address. Healthcare-associated infections are one of the most common adverse events in delivery of care and present a significant economic burden for the health system. And nurses indeed play an important role in the care of patients and preventing healthcare-associated infections. Pfizer's partnership with Americares India Foundation has developed a free online open learning platform on AMR that will offer certification programs on various aspects of infection prevention and control. And to talk more about the Open AMR, I would like to invite Mr. Shripad Desai, Managing Director, Americares Foundation of India, to talk about this, the Open AMR. Over to you, Mr. Desai.
Thank you, Anisha. Good afternoon, everyone. And just let me share my Yes. A very good afternoon and a warm welcome to honorable dignitaries, esteemed panel members, and all the delegates. It's indeed my privilege to share about Americares India Foundation in brief and then about Open AMR platform to each one of you. Americares India Foundation is a health-focused relief and development organization that responds to people affected by urban poverty and disaster with life-changing health programs, medicines, and medical supplies for the last 45 years. We started our efforts in India in 1993 and established an office in India in 2006. But it is in 2011 that we started our journey in the space of health workforce safety and infection prevention control with a pilot project at Mumbai's Jagjeevan Ram Hospital, which was then followed by a holistic IPC project with India's leading KEM hospital, Department of Microbiology, and followed by a 3-year-long project with the Sion Hospital. By 2017-18, when the National Action Plan on AMR was on, we realized the need for aligning our efforts with the National Action Plan, and it is that what triggered the partnership that Mr. Sharad spoke of just now. So it is with that objective, Pfizer and Americares have partnered to launch 2 programs. One, Project Parivartan, which is a project which is aimed at building institutional capacity towards IPC and AMS, and the Open AMR platform, which is aimed at building the capacity of nursing professionals. While my colleague Dr. Rahul will dwell in detail about Project Parivartan, I want to mention that today the world is celebrating a World Accreditation Day, and Project Parivartan is aimed to move our partner hospital one step closer to a NABH accreditation. We all know the important role the nursing professionals play in reducing the HAIs as well as controlling the use of antimicrobials. The Open AMR platform, which is an acronym for online platform for education among nurses on AMR in regional language, is our effort to ensure that the quality learning reaches to the nurses across the country. We believe that there is a need for free online learning management system in Indian languages. And as we all know, the increasing infection rates with multi-drug resistant organisms have become a global emergency. COVID-19 obviously has increased the infection exposure to nursing professionals and paramedic staffs. Excess workload and lack of education leaves prevents our nursing professionals from professional development. And therefore, we felt that there is a need for a platform that can enable learning in Indian languages about the practices which can be followed in India. And therefore, with the project goal of creating a platform that could be accessed anywhere, anytime learning, offering free online LMS in regional languages is something that was conceived and branded as Open-AMR. This platform is very user-friendly and, like I mentioned earlier, can be accessed in 7 languages. So to begin with, in first phase, in Open AMR, we have 6 certificate courses being offered to the nurses across the country, or rather across the globe. There are 7 languages in which they can access the course. It includes English, Hindi, Malayalam, Tamil, Telugu, Kannada, and Marathi to begin with. The total coursework, if a nurse has to undertake, it's about 11.5 hours. But as I mentioned, it's divided over 6 courses, so it can be taken at her convenience. And at the end of each course, there is a test to assess the knowledge transfer as well. Some of the key features are that it's 0 course fees. There are courses available on the net, but the nurse has to shell out money. So this is completely free of cost. It's very easy registration process. It's in Indian languages. The nurse can take the course at her or his speed. The course content is curated by subject experts, and its simplified course content is available. At the end of each course, the nurse would get a certification that is available, as you can see on the screen. And I must mention here that we are in exploring partnership with professional bodies like TNAI to come on board, so that this unique platform can be reached out to each and every nurse practicing in every state and every part of the country. So with that, I'll hand it back to Nisha, and I'll maybe stop here. Thank you very much.
Thank you so much, Mr. Desai. This does sound like an exciting platform where people can learn, nurses can learn at their own pace in the language of their choice. Really a remarkable effort from Americares Foundation and Fizer India. Now, I would like to invite our chief guest, Mrs. K.K. Shelja Teacher, the Honorable former Minister for Health and Family Welfare, Government of Kerala, to please address the audience. Welcome to the show, ma'am. We are all waiting to hear you.
Thank you very much. Respected dignitaries who are participating in this discussion, my dear brothers and sisters, I am very happy to be here because we are discussing a crucial challenge the world is facing through antimicrobial resistance. After this COVID or post-COVID arena, it become too much important because we are using so much antibiotics, and the antimicrobial resistance become again a villain, again an enemy during this time. But I'm proud to be saying that in Kerala we started the fight against AMR when I think when I was in office, or I was Minister of Health last time, 2016 to 2021. At that time, my health secretary and all other experts and me sit together and discuss the plan for antimicrobial resistance action plan. And Kerala launched a very good strategic action plan. After so many discussions, we drafted a strategic action plan, and Kerala Antimicrobial Resistance Strategic Action Plan. In short, it is known as KARSA. And I think it was the first in India who launched an action plan on antimicrobial resistance. And it was appreciated throughout the country. And also in our workshop from other states, also there were participation. And with the help of WHO and the other organizations who are dealing with the antimicrobial resistance, we had a very good discussion, and we had an action plan. The action plan is aimed at giving strategic direction to various activities undertaken to tackle antimicrobial resistance. And the action plan is truly One Health in its approach and was developed through collaborative exercise involving human, non-human, and environment sectors. We all know that we cannot tackle this AMR problem without adopting the One Health approach, and that is why in our discussion we have a collective approach, and we invited all other health department under the health department's leadership. We invite all other stakeholders like veterinary, fisheries, and all other environment. Everyone we invited, and we prepared according to that, according to the One Health approach. Jointly, we developed the by the departments of agricultural development and farmers welfare, animal husbandry, environment, fisheries. We developed a action plan, and the objectives envisaged under the Antibiotic Literate Kerala campaign are: one is the universal awareness about the importance of having access to antibiotic-free food and water, and universal awareness about the importance of consuming antibiotics only on doctor's prescription, and the universal awareness about importance of safely disposing unused date-expired antibiotics. For this, we have an organization or a campaign called PROUD, P-R-O-U-D, Program on Removal of Unused Drugs. And under this campaign, PROUD, we collected tons and tons of unused antibiotics, and the antibiotics with the date expired antibiotics also we collected, and we transmitted that to the that proper place to remove that or to destroy that. And awareness among school students of the threat posed by AMR also was under our campaign. We had a very good campaign, and we had a very good network to examine all these activities. There were some points of leadership that our medical college, the Trivandrum Medical College, was one point, and also one of the general hospitals in Ernakulam, that is in middle Kerala, and two ends of the Kerala, south and north. There were some institutions which are leading this campaign and these activities. And at last, when we completed, not it is going on, but when that tenure stops in 2020, we have 17 centers to check or to identify the antimicrobial resistance. And when we examined in Kerala, we found AMR, antimicrobial resistant pathogens. There are 6 pathogens, antimicrobial resistant pathogens we found in Kerala, and we have different activities to prevent the spreading of that kind of pathogens. The Acinetobacter spp is here, and E. coli is here. Klebsiella, that is also here. Similarly, Pseudomonas aeruginosa is here, and Staphylococcus aureus is here, and Enterococcus spp. These we find these are the most dangerous thing, and the dangerous 6 pathogens we found in Kerala, and we started our action through creating awareness among healthcare workers, and also to propagating these things to the public, and we started our action plan like that. Today we are continuing this thing, antimicrobial resistant campaign. We are continuing, but the most important thing is to create the infection control or make infection control in hospitals and also in proper places. And we have several trainings and several kinds of activities to do the infection control. That is the most important thing. I started every kind of activity. I am not elaborating everything, but the most the real threat that is a big business. When we are making or buying feeds for the cattle and sometimes the poultry business, we found that the food itself contains antibiotics, and when we eat that meat, that also becomes some dangerous thing, and we cannot all of a sudden control all this business, because all the business are related to profit making, and the safety measures are not taken by the businessmen, and we are now persuading them. But the small scale businessmen, what can they do? That is the most important question. We should provide them some animal feeds or instead of these foods, but it is not very easy throughout the world. I think that is become the most important problem to in front of us for who are fighting against this antimicrobial resistance. And we insisted as much as we can. We create awareness in people that you cannot swallow everything you get as medicine, and without prescription you cannot buy these antibiotics. And we create awareness among the doctors also that you should prescribe antibiotics for the necessary, the right time at the right prescription they should give. But in most cases, when we examine the most cases, they are giving, most of the doctors, even if they got a cold, say a simple flu, and the people are going to them, a large number of doctors are prescribing heavy doses or courses of antibiotics. We through our campaign we can reduce it, to a great percentage, but I cannot say that the 100% they become aware about this. But a very good result Kerala is getting throughout this campaign, and we should control these big businesses also, and the world should unite. All the rich countries should create awareness, and they should spend some money on this also. The poor countries cannot do more on this issue. But after the COVID, post-COVID days, the most important and crucial threat human being facing is this antimicrobial resistance. And during this COVID season also, if it is Omicron, some scientists are saying there is a chance to get infections, and they should so the patient should use antibiotics. And there is not a clear cut. I think there is not a clear cut suggestion or that kind of thing, and we should have to find it which is correct and which is not we can use. And we should the experts should make a very good suggestion or decision how much extent we should use antibiotics and how extent we should avoid these things. And it should be a collective process throughout the world. In Kerala, we are proud that we can do during these 5-6 years we were working on it, and we achieved a very good result. And now the people are asking the doctor whether it is necessary or not, and doctors are also suggesting it is not necessary, or you should use up to this time. This course is like that. After the course you could not continue antibiotics, etc. And we are collecting the unused antibiotics also. We are giving awareness to the small scale businessmen also, how much extent you can use the safety food other than this thing. But we should have a joint action, I think. I am very happy that you invite me also in this meeting. And after this discussion, I think there will be a very good result or very good suggestions to circulate throughout the world. Our this CARSAP or this action plan, we published our activities in one of the world international journals and also 2 national journals under the leadership of the General Hospital Ernakulam. We published these activities in 3 journals. That one is international and other is this national, 2 are national one. And we should also publish, I think, now I am not in the office as minister, but our government is continuing all these good activities. And I think in future we can give more good result out of our activities. That's all. Thank you, everybody.
Thank you, ma'am, for giving us a holistic picture of the situation as it is on the ground level. And of course, it will take concerted action from everyone, from the government, from private players, from drug companies. Thank you so much for joining us. I would request you to please stay back and unveil the Open AMR, a learning platform to train the nurses, to train them on infection prevention and control.
Okay. Yeah. Pardon, you're asking a question?
Ma'am, please stay. We are going to give you a preview of the learning platform that has come. We request you to please stay to watch this.
I cannot hear well, but I think you are asking about the learning practices, and that is, isn't it? You are asking about the training and something.
Ma'am, the Americares Foundation and Pfizer has come up with Open AMR, a learning platform for nurses. So we just want you to have a look at this platform. So just stay for a minute, ma'am.
Americares India Foundation and Pfizer have partnered to bring to you India's first free dedicated online learning platform for the education of nurses on AMR in regional Indian languages. Open-amr.org. To begin with, Open-amr.org will offer 6 certificate programs in IPC and AMR in English and 6 Indian languages including Hindi, Malayalam, Tamil, Telugu, Kannada and Marathi. Course contents are curated by subject matter experts from Midversity.
इस विषय में स्वास्थ्य सेवा से संबंधित संक्रमण और संक्रमण की रोकथाम और नियंत्रण आईपीसी मानक विधियों का परिचय कराया जाएगा.
Offering opportunity with flexibility to learn at any time from anywhere. Once you complete the course, you will receive a digital certificate to be downloaded.
Initially, I was concerned about the Open AMR platform since I have not used such things before. But I find this to be simple and easy to use.
I found it very impactful for nurses like us to watch to improve in terms of knowledge and better nursing practices.
डेली बेसिस क्वेश्चन आते हैं, उससे मुझे बहुत हेल्प मिलती है, जो कि आसानी से पढ़ने में भी आसान होते हैं और समझने में भी आसान होते हैं.
और मैंने ये OLP कोर्स किया है, जिसके थ्रू मुझे बहुत सारी चीज़ों के बारे में नॉलेज मिली है, जिसमें कि आपको बायोमेडिकल वेस्ट के बारे में, पेशेंट केयर के बारे में और छोटे छोटे बहुत सारे सब्जेक्ट्स हैं जिसके बारे में आपको जानकारी मिलती है.
सबसे अच्छी बात तो ये अपनी मातृभाषा हिंदी के अंतर्गत ये आता है और मैं अपने कलीग दोस्तों को भी बताऊंगा इसको पढ़े, सुने और समझे.
The Open AMR Project by Americares India Foundation is a CSR initiative by Pfizer.
For coming up at Open AMR. Now I would like to request Dr. Atul Goyal, Directorate General of Health Services, Government of India, to please address the audience. Mr. Goyal is just going to join us. He was with us during the proceedings. got an offer of emergent work, but will be joining us in just a minute. So I request for everybody's patience for a minute.
Americares India Foundation and Pfizer have partnered to bring to you India's first free dedicated online learning platform for the education of nurses on AMR in regional Indian languages. Open-amr.org. To begin with, Open-amr.org will offer 6 certificate programs in IPC and AMR in English and 6 Indian languages including Hindi, Malayalam, Tamil, Telugu, Kannada and Marathi. Course contents are curated by subject matter experts from Midversity.
इस विषय में स्वास्थ्य सेवा से संबंधित संक्रमण और संक्रमण की रोकथाम और नियंत्रण आईपीसी मानक विधियों का परिचय कराया जाएगा.
Offering opportunity with flexibility to learn at any time from anywhere. Once you complete the course, you will receive a digital certificate to be downloaded.
Initially, I was concerned about the Open Amr platform since I have not used such things before. But I find this to be simple and easy to use.
I found it very impactful for nurses like us towards to improve in terms of knowledge and better nursing practices.
डेली बेसिस क्वेश्चन आते हैं, उससे मुझे बहुत हेल्प मिलती है, जो कि आसानी से पढ़ने में भी आसान होते हैं और समझने में भी आसान होते हैं.
और मैंने ये OLP कोर्स किया है, जिसके थ्रू मुझे बहुत सारी चीज़ों के बारे में नॉलेज मिली है, जिसमें कि आपको बायोमेडिकल वेस्ट के बारे में, पेशेंट केयर के बारे में और छोटे छोटे बहुत सारे सब्जेक्ट्स हैं जिसके बारे में आपको जानकारी मिलती है.
सबसे अच्छी बात तो ये अपनी मातृभाषा हिंदी के अंतर्गत ये आता है और मैं अपने कलीग दोस्तों को भी बताऊंगा इसको पढ़े, सुने और समझे.
The Open AMR Project by Americares India Foundation is a CSR initiative by Pfizer.
Let's now move on to our first panel discussion of the day on the challenges in infection prevention and control in hospitals and the impact of COVID-19 on IPC practices. I would now like to introduce the experts on this session. Please welcome Dr. Camilla Rodriguez, Consultant Microbiologist, Chairperson, Infection Control Committee, PD Hinduja Hospital and Medical Research Center, Mumbai. Please also welcome Dr. Dhruva Chaudhary, Senior Professor and Head, Department of Pulmonary and Critical Care Medicine, PGIMS Rohtak. Please welcome Ms. Urvashi Prasad, Director, Development Monitoring and Evaluation Office, NITI Aayog. Please welcome Professor Dr. Roy K. George, National President, Trained Nursing Association, India, and Dr. Rahul Kamble, Project Lead, Parivartan, Americares India Foundation. And to moderate this session, I would like to invite Dr. Nalini Kaushik, Principal Consultant, Policy, Advocacy and Government Affairs, AMR Council. A warm welcome to all of you, and I'm going to hand it over to Dr. Nalini to take this discussion forward.
Thank you so much, Anisha. This was indeed a great start to the Anti-Microbial Summit today. Good afternoon, everyone. I am Dr. Nalini Kaushik, and I welcome you all to the Anti-Microbial Summit 2022. Now, as we all know that antimicrobial resistance is a global health crisis that is threatening a century of progress in health. It is hindering the achievement of sustainable development goals and the achievement of universal health coverage as well. Now, the alarming levels of resistance have been reported in countries of all income levels, with the result that common diseases are becoming untreatable and life-saving medical procedures are becoming riskier to perform. So now in that case, strong infection prevention and control is a most effective approach to controlling the spread of AMR. Now focusing on the same, in our first session today, we will be interacting with our experts in challenges faced in infection prevention and control in hospitals and the impact of COVID-19 on IPC practices. So I would like all our panelists today to just come on the camera as we begin the conversation. Thank you so much. To set the conversation and to set the context today, Dr. Dhruv Chaudhary, I would like to begin with you. That of course while we will be entering into the nuanced discussion, but if you could firstly help us understand that what is IPC in the context of AMR, and what are the different hygiene practices in the ICU to prevent healthcare associated infections caused by the organism and sometimes also the MDR organisms.
Thank you, Nalini. And I also thank IHW for considering me and having my viewpoint. And it's great to be seeing Dr. Camilla Rodrigues and other colleagues. I think it's very relevant when you're talking about infection prevention and control practices. There's nothing more relevant than actually in the whole hospital day-to-day life, but ICU is the key, because more than 50% of your hospital-acquired infections, if you look at the data, are coming from the ICU. And more to it, the last line, if I take what you said, MDROs.
Yeah.
They are actually the factories of MDROs. So that's what we are seeing. And the context, again, before I come to that, there are two things which are very important where we are different from the West, has been especially the gram-negative organism, the way it is there. And I was listening to Honorable Health Ex-Health Minister of Kerala. The 6 organisms she talked about, basically you look at the big 3 here, continues to be Acinetobacter, Klebsiella, Pseudomonas. We don't have that much of a challenge with the Staphylococcus MRSA, but multi-resistant methicillin-resistant Staph aureus. But definitely we are seeing a significant increased number of Clostridia difficile, and also fungal infections also started coming up in high, especially Candida auris. Now, having said so, if you see in terms of infection prevention and control practices, we all talk about it. But it's very easy to talk hygiene practices. It's very challenging and difficult, because the environment in which we are having it, and in particularly COVID, on the one side, we were looking at outside, putting a lot of emphasis on different practices. But when we went inside the wards, we could see everything being broken. They were breached. Reason is 1 patient, 2 patient, practically all wearing those, the space suits, or you may call it the PPEs, and then going from 1 patient, 2 patient, 3 patient, they may be protecting themselves, but we did not see as much protection. And in fact, we saw a lot of breach in infection control practices from a patient to patient. Having said so, when we start looking at it, I think the importance and role cannot be understated. It is the key. Prevention is the key. And single important thing which we are putting lots and lots of emphasis is on hand hygiene. And that's what we are looking at. That is practical. That is feasible. The only thing is that you need to have availability of soap and water.
Yeah.
Or if you can have it now, we are looking at the new synthetic preparation where you have alcohol-based, or you have a chlorhexidine alcohol. Whatever rest of the things we are talking, we did try lot of protocols, lot of things, and our nurses played a lot of role. But few things which I would like to highlight is that we try to have a separate articles for separate patients. We try to put a disinfection protocols. We try to change linen every day. And when we change linen, what we did at that point of time, because in the beginning we were not aware how the infection is started. Is it a droplet infection? Is it a surface infection? So what we used to do was we used to put into hypochlorite. From hypochlorite, we used to send it for the sterilization, then washing and coming up. But in the process, because of the use of hypochlorite, a lot of linen also got damaged. which sometimes we don't realize becomes not cost effective. Secondly, when we start looking at infection prevention control practices, as you say, why we need to do it? We need to prevent development of drug-resistant organisms, because otherwise we will go into pre-antibiotic era. And if we reach into pre-antibiotic era, probably we shall be again getting into the same experiments which were done in the medieval Europe, or let's say in 1800th century in Vienna, where hand wash was found to be useful. So one infection control practice which has been consistently found to be effective in preventing is a hand wash. How much it is being done, it is unfortunately is not commonly practiced, but you need to keep on emphasizing, re-emphasizing that is what is needed. Second is when you start talking in terms of infection control practices and AMR, you made a mention of it. I think in the AMR, besides this, proper prescription of antibiotics, appropriate use, when you start with an empirical antibiotic, proper de-escalation, use of biomarkers. So it is becoming a complex issue. And one of the biggest barriers in implementation, which we are seeing and which we have observed and which we have detailed, at least in our institution, in our state, has been the attitude of the medical professionals. Not that much of the nurses. They go with you, but they feel that they have been disenfranchised as a quote unquote, or they have been fanned down. So I think what is very important we need to take when we talk in terms of antimicrobial resistance, without looking at the manpower, without looking at the hygiene practices, they are of no use, though we may talk, as ma'am was talking about, use in poultry, use in other things in food products, that's one part. But looking at infection, I give you one example of my institution, my department also. We did study, one of the 4 big hospital-related infections we are seeing is like VAP, ventilator-associated pneumonia, which is a part of hospital pneumonia. We did a study in around about 7 years, 8 years ago, and got it published in Indian Journal of Critical Care. Our incidence of VAP was 57%. And we started looking at it, what are the reasons? We found out adequate staffing is as important a part which we tend to forget. Because if a nursing assistant has to look at 5 patients, 4 patients, 3 patients, probably, and if they have to spend more than an hour washing their hands on 1 patient and 5 patients, they have to do 4 hours, but when will they work? So let's look at the practical aspect of it. Then we started putting these practices and we were able to reduce it to around about 22%. So the point is what we did simply 2 things. We ensured adequate hand wash before doing suctioning, before providing a good oral care. We all forget good oral care. Similarly, when we are handling the central line, the CLAPSIs, etc., it is as important how we put the line. So key in the prevention is again repetitive, though, is hand wash 1, proper care, wherever possible, disposable, we used it. And in the context of the COVID, we ensured as far as possible, we provide sterile things as far as possible, but within the ICUs, because of the loads, because of other things, we did find breaching and breaking of IPC practices.
Right. Thank you so much, Dr. Dhruvan. I think like this was you very beautifully set the context for today's conversation, first of all, and how simplistically you explain the on-ground reality, especially in the context of hospital level situation, and also taking the kind of measures, be it in terms of hand hygiene or training of the healthcare professionals, etc., that you've talked about. I think this was a 360 view of the context that we are talking about here today. And we're taking a cue from you. I would move on to Ms. Urvashi Prasad, because we've heard medical practitioner's perspective here on AMR, and in the introductory session as well today we've been hearing about the programs and all. But as of what we understand, that policy becomes a very important guidepost when we have to implement programs of IPC, AMS, etc. So if you could just help us understand, and from your perspective, what do you think that what is the role that policymakers first of all can play, and what is the kind of progress? Because of late India has been very consistent when it comes to taking measures in preventing AMR and in containing the same. So what is the progress that India has made after the implementation of the AMR program? Over to you, Ms. Prasad. I'm so sorry to cut you, but you're on mute. Yeah.
Am I audible now?
Absolutely. Please go ahead.
Thank you. So so AMR, of course, it's a very important policy issue, and the context has rightly been set here in terms of the different elements that we need to look at. So I think from the policy point of view in AMR, we have, of course, national level plans and policies that have been put in place, and certain pledges have been taken at the national level, where all stakeholders have come together to say that we are actually going to address this critical issue. But I think what we actually need is to translate those national level plans into also very effective state level plans, because not all states have these plans currently in place. And we also need adequate funding along with the plan, because while you might have certain standards, you might have certain guidelines in place, to actually be able to enforce those, you need adequate funding. So I would say that we need to also translate these national level, just like in Kerala, we have many success stories. We need also similar success stories from other states. So that is something that I think is very, very important from a policy point of view. The other is, of course, the engagement of all the different stakeholders. So, this is not a one sector issue. This is a multi-sectoral issue. We mentioned it's not just about, irrational prescription of antibiotics, but it's also hand hygiene, it's, hand washing, it's sanitation, it's access to, clean water. So there are so many different issues that need to come together. So we need this multi-sectoral approach also. And that is also very critical from the policy point of view. And we need multiple stakeholders to be engaged. And we need to involve all the different stakeholders, when it comes to things like irrational use of antibiotics or prescription of antibiotics, all the prescribers, everybody who is in the ecosystem, both in the public sector as well as the private sector. Because we have to remember that so much of healthcare is actually provided in the private sector. So whenever we are talking about healthcare and policy, we can't just talk about the public hospitals or the public sector, but equally we have to talk about the private sector, the very large private sector. So we need that public-private collaboration to also come in. And we need different stakeholders, we need different sectors, as I said, because this is not something that can be addressed if there is only, one sector or one set of stakeholders that is looking at it. So that is, I think, the other very, very important point to be made from the policy point of view. But overall, I would say that we need to have these big national level plans translate into actual state level plans and, even sub-state. And have adequate resources, financial, human resources, training, because there's so much training, capacity building that needs to be done, information sharing. So all of those things need to be translated into at the state level and also at the sub-state levels. Thank you.
Absolutely. Thank you so much, Ms. Prasad. And I think what you've just mentioned, it definitely tells us, first of all, the priority the government has put towards AMR and at various levels, be it global platforms at the national, and also we need to sort of take it to the state level as well. And with that, I would move on to Dr. George here. So my question to you is that like we've heard medical practitioners' perspective. We have understood the situation, what is happening on ground in the hospital settings, and then Ms. Prasad telling us more about how the policy needs to feed in, and how a multi-stakeholder approach or a private public partnership can also play a critical role there. But in middle of all of this, there's a very important stakeholder group that we absolutely cannot miss out, is the nursing staff that we have, which is very critical. And I think just taking the liberty of quoting the pandemic that we just faced, or currently we cannot know that where we are, but nurses played an extremely crucial role, and I think whatever I say would be an understatement to the nursing community. So what do you think, now if we talk about, connect all the dots here and connect, the aspects of AMR here, how do you think, the nurses, would be playing a critical role when it comes to implementing IPC practice in the hospitals. And, if you could just help us understand that, what are the critical challenges that they face more importantly?
Yeah, thank you, Nalini, for the opportunity to participate in this very important panel discussion. And as all of us know, infection prevention and control practices in any healthcare setting is a very important issue to be addressed, whether it was pre-COVID or during COVID or post-COVID, because it was there always. So there are estimates that many of our clients or the patients acquire hospital-acquired infections during the period of treatment in critical areas especially, and even in the general wards. It is due to the lack of proper infection control practices. And when you take the nurses' role, see, nurses are the people who are there with the patient 24-hour basis. Though the nurses may change in the shift, but there are nurses always. And those people who handle so many patients in the hospital and who can be a carrier of infection from one patient to another because of inadequate staffing, inadequate non-availability of adequate equipments and care instruments, which may be shared, which may not be sterilized properly, or low quality of instruments or equipments right from the needle which we use for injection or to a catheter which we use to suck. And Dr. Dhruv Chaudhary was saying about the ventilator-acquired infections and things like that, which occurs in the high dependent units or critical care units. In all these areas, first of all, adequate staffing is very important to ensure practice of what we teach or what we talk about, because it is easy to talk about, but in the practical situation when there is understaffing, if a person goes for a proper hand washing and all those protective equipments to avoid infection, maybe the patient will get worse because of lack of care. That is the crucial situation where we face. Because of inadequate staffing is not a situation which is present now. It has been there for decades, and it is worsened with the COVID pandemic. Nurses in large numbers are moving out of the country at present because there is a huge demand for nurses, especially in countries like United Kingdom, Ireland, and the Middle East. Even the World Cup has affected or enhanced the migration of nurses to Middle East, especially Qatar. There are so many health facilities. So there is definitely a shortage of nurses who are experienced. Maybe we will get freshers, but people who can lead a team of infection control nurses. And many of the hospitals, because of the last 1 or 2 decades, infection control teams have been in place in many of the hospitals, especially in the pioneering institutions in the government as well as in the private sector. But though they have standard operating protocols and infection control guidelines, on the ground, how much it is practiced, that is many times a difficult situation, because though we talk a lot about health team and we work as a health team, in Indian society where a doctor-centric or doctor-led program is there, many times our senior doctors themselves fail in observing the infection control practices, which nurses are not able to correct. If the nurses try to correct, it is not the doctor gets corrected, the nurse may be thrown out because she has insulted a senior doctor. Because they have been in the practice for the last 5 decades or 6 decades. They are veterans in the profession, but many of them may not be following the infection control practices. When a junior nurse goes and tells, "Sir, this is the situation, you have to observe this," that is not taken usually in the correct spirit. That's why I told, though health team concept, everything is there, that is not actually runs in the practical situation. In many situations, we have seen it during COVID, before COVID, and also now we are seeing that continuously. That there is NABH accreditation. There are a lot of standard operating procedures, protocols, all in paper and all framed in and kept in documents in our desktop computers. But what is actually done is same thing which was done in 20 years or 30 years ago. And this happens in the practical situation because it's a closed-door panel discussion. I am opening up there. This is happening almost everywhere. There are exceptions, but almost everywhere. This leads to repeated infections, and those people who are in the committee or the infection control guidelines, they observe guidelines, they make recommendations, but they are not empowered to insist and implement it, except in few places where there is real groundwork is going on. So that is one thing. Second is that this large rate of turnover of nurses who are though they are qualified, who are trained for infection control or to take up risk, the turnover is very high, especially in the private sector, which meets at least 70% or 80% of our healthcare. It is because of there are multiplicity of factors, because our remuneration package is low, people are getting better jobs outside, or they move to with the starting of so many All India Institute of Medical Sciences, there is large scale movement of nurses from the private sector, government sector, because the pay cycle. So what happens is the healthcare sector, which is almost 70 to, which means almost 70% of healthcare in this country, again faces acute staffing shortages, which affects this ongoing training and improvement in patient care. So, but there are a lot of policy changes needed as far as like where Dr. Chowdhury started, staffing norms has to be implemented. And we have only a 1973 staff infection unit norms to place nurses, whereas the medical care or healthcare has become so complicated and so ultra modern, and where the staffing is still inadequate, both in the government sector and private sector. So this affects the whole spectrum of care, and whatever is said and done, nurses are the people who coordinate the care. They're not the leaders, I agree, that is doctors, but who coordinates the care, who sees that the care is implemented on a 24-hour basis. If that part is not strengthened and they are not taken care to stay with the patient, a team is there, all these successes may not reach what we expect, may fail well below 50% of our effort. That's the point I want to make.
Thank you so much, sir. And I think whatever you talked about, of course, that first of course shows the kind of in depth that you are with the community and supporting the entire nursing community across the country to pick up the challenges and also work in a more constructive manner towards them. And I think these are some very serious challenges, and I think how we are gathered here today to be talking about these things is maybe gives us sort of hope that we need to move forward with bringing more solutions. And since we are talking about solutions now, we have Dr. Rahul here with us. Towards the beginning also we talked about the program Project Parivartan, how it is also helping us bridge those challenges and bring more solutions. So Dr. Rahul, I would like you to answer specifically and give us more details about Project Parivartan, because we heard a bit about that from Mrs. Shripal in the beginning as well, that what is the project, and then how is it really supporting the kind of bridging the solutions or bringing the solutions to whatever we are discussing here today. Over to you.
Sure. A very good afternoon to all, and thanks for the introduction, and thanks for allowing me to share my presentation. Shall I move with my presentation here? It's indeed a pleasure to speak on this esteemed platform on behalf of Americares India Foundation about our Project Parivartan. Project Parivartan aligns to the 5 priorities of National Action Plan on Antimicrobial Resistance, which includes: first, improve awareness and understanding of antimicrobial resistance through effective communication, education, and training. Secondly, strengthen knowledge and evidence through surveillance. Third, to reduce the incidence of infection through effective infection prevention and control. Fourth, to optimize the use of antimicrobial agents in health. And lastly, to strengthen India's leadership on antimicrobial resistance. The term Parivartan implies change or to bring about improvement. Herein, the project goals includes to contribute to the National Action Plan of against antimicrobial resistance in achieving its objectives of antimicrobial stewardship for human health. Second, to demonstrate measurable improvement in key infection control parameters in the selected 11 mid-sized hospitals. Third, to build a model for institutional capacity building to achieve facility-based infection control and antimicrobial stewardship. Lastly, to build a capacity of key stakeholders on antimicrobial resistance for human health. The project runs across 11 hospitals over 7 states of India. 4 of them in Maharashtra, 2 in Madhya Pradesh, 1 each at Gujarat, Rajasthan, Uttar Pradesh, and Tamil Nadu. So these 11 mid-sized hospitals have a bed capacity of 100 to 250 beds, with an availability of a dedicated microbiology lab and full-time microbiologist and an in-house pharmacy. The selection criteria for these hospitals also includes a preparedness for pre-NABH or NABH accreditation. The project covers runs across 4 stages over the 2-year period. We are already finished up with the stage 1. The stage 1 includes baseline assessments, which involves assessment of the hospitals for infection control and antimicrobial stewardship practices, wherein we use the NCDC and CDC and WHO assessment tool. The stage 1 also involves gap analysis for infection control and antimicrobial stewardship using the NE-based standards. We are ongoing with the stage 2 and the stage 3. Stage 2 includes capacity building and gap closure, which involves to review and set up standard operating procedures and policies for infection control and antimicrobial stewardship. Then infection control and antimicrobial stewardship training for the healthcare personnel. Then to facilitate gap closure, and finally the gap assessment, that is knowledge, attitude, and practices assessment of the healthcare personnel. While stage 3 includes surveillance and monitoring, wherein it involves tracking of healthcare-associated infections such as ventilator-associated pneumonia or central line blood infections or catheter-associated urinary tract infections or surgical site infections. Then it also involves tracking of multi-drug resistant organisms, adherence to antibiotic policy, and since infection control and antimicrobial stewardship is a quality improvement project, this stage also includes feedback course correction using the Plan, Do, Study, Act tool. And finally, the stage 4, which includes certification and dissemination, which involves certifying these hospitals as a center of excellence for infection control and antimicrobial stewardship by CAHO, that is Consortium of Accredited Healthcare Organizations. And it also involves presentation and publications of the facts and figures of the projects, and finally advocacy. We have identified key performance indicators for the performance evaluation of this project, which includes on the basis of timeline as short-term outcomes, medium-term outcomes, and long-term outcomes. The short-term outcomes includes to increase knowledge about the health workers about infection control, then increase knowledge of infection control and stewardship surveillance, then increase knowledge among healthcare workers about antimicrobial stewardship. While the medium-term outcome includes increased adherence of evidence-based practices for reduction of healthcare-associated infections with a special focus on hand hygiene. Then it also includes increased adherence of evidence-based practices for antimicrobial stewardship with a special focus again on to see the compliance towards the antibiotic policy. And finally, the long-term outcomes includes to bring about a reduction in health device-related healthcare-associated infections like VAB, CLABSI, CORTI, and XI. And since healthcare-associated infections run in parallel with the incidence of drug-resistant organisms, our long-term outcome also includes to bring about a reduction in the incidence of multi-drug resistance pathogens. For the surveillance and monitoring, we have adopted for infection control, we have adopted the WP tool, the 8-component tool for surveillance of infection control, which includes IPC programs, guidelines, education, surveillance, audit and feedback, enabling the environment, and multimodal strategies. It's very early to share the results of this our project, but within the 2 to 3 months of the launch of our project across the hospitals, we have seen a mild, though not significant, reduction in the incidence of healthcare-associated infections. We also have seen an improvement towards hand hygiene, which is a very single effective measures to prevention and control of healthcare-associated infections. For the antimicrobial stewardship, we have adopted the 7 core element tool of CDC, which include leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education. Herein, it's too an early stage to come to share the results, but we have been monitoring in this project for the incidence of multi-drug pathogens, then the antimicrobial consumption in terms of the pandemic doses, and we also check for the compliance towards the antibiotic policy, such as dose optimization, pre-authorization, and other such interventions of antimicrobial stewardship. It's said that eyes don't see what the mind doesn't know. Knowledge and education forms a key role in if you want to bring about the improvement or for the capacity building of infection control and antimicrobial stewardship. So our main focus is on education and trainings, which includes classroom trainings, bedside trainings, and virtual trainings. We have partnered with CAHO for the certified training courses on infection control and antimicrobial stewardship, which take place on a quarterly basis. And here also we are very delighted to share about the launch of our Open Amr platform, which is an online platform for education of our nurses against antimicrobial resistance, which is a serious killer pandemic going on. So that's the end of my presentation. I thank you the participants for the kind attention and open for the questions.
Right. Thank you so much, Dr. Rahul. And I think with all the discussions that we've had with, the West stakeholders so far, I think we have been talking about the challenges, the problems, and, what could be the plausible solution. And what you just talked about, the entire platform, the project, I think that is one of, the solution that we have in hand, when it comes to the fueling problem of AMR in India. At the same time, when we are talking about, AMR and the infection IPC practices here, I think we cannot really, move forward without talking about the experience that we had during COVID-19 pandemic, in India. And I think this is more like, an open question to many of the panelists that I have in the session 1 today. But Dr. Dhruv, I'm going to start with you here that, we have talked about the challenges at various levels in our health systems, etc. But during the COVID-19 pandemic, how did, it's sort of in your institute per se, because, I'm sure you must have been, on ground witnessing the entire situation. So in your institute, how did COVID-19 in fact impact the IPC practices and what was the outcome?
I think it's a very relevant question. And being myself as the nodal officer of the institute as well as the state, when we started up, we were just looking at how to go ahead with it because we had 2 issues. One is the conventional IPC practices, and second is how we are going to handle the prevention of COVID from the hospital so that they don't become a hotspots, and also large number of people who have been going back to their home may not get the infection, because in the first wave that panic was real. In the second wave, I may say so, the medical professionals are far more relaxed as far as this aspect was concerned. Probably adaptability has taken place. First and foremost, you will laugh at it, what I'm saying, on naivety or the thing. People got much more aware about the term IPC. Yeah. Because till now, it was just being discussed in the by the ID specialists or by the people in the intensive care or some consensus Indian Association of Microbiologists. So they were all discussing, talking about, and sometimes the pharmaceuticals also making noise here and there, more of because their products being getting into a different aspect and they brought it up, the thing. So it's a very multifaceted thing if you really look at it. So first and foremost is the people who led from the front, again I may say so, were the nurses. We created an IPC team, though we had a hospital infection control committee, but trust me, these committees more work. But because I come from the public sector, I'm very, very, very blunt and open about it. Because most of them, they meet, they talk, they do about it, they do disseminate, but there has been no direct studies or the auditing what practices are being used. So we looked at it, how we are doing, we realized that not more than 20% or the 25% of the people are using hand hygiene. That is the first thing which we realized. And that's where we started emphasizing and training the people. Because it's good in seminars to talk about, but the ground realities are much, much different. So the first thing when we started with our IPC practices, and when lockdown was there, other thing was there, it sensitized the people. So acceptance was much easier, one. Secondly, we went to the undergraduate classes, school, and talked to them about the different steps. And that is where we all used to work. We created videos, we created things. Other educational material within the institution for training, and all of you are very well aware about the acronym which we all use, especially in Hindi, the Suman K, Sida, Ulta, Mutti, Angutha, Nakun, and your Kalai. So that's how we looked at the 5 to 6%. That's what we trained. That is point number 1. Second, then we realized because it is being spread when we started looking at infection and how to prevent a droplet infection or there, because we looked at it like from the beginning, we are talking about droplet for all practical purposes. It was aerosol, though there was a lot of debate. At that point of time, I was heading the Indian Society of Critical Care Medicine as its president. So we talked about it and we went straight away into in the aerosol practices. But at the same time, there was a lot of confusion also that the practices which you are using in intensive care may spread, like your NIVs, your CPAPs, etc., or hypronasal cannulas. But nevertheless, first and foremost, which later on the government of India also came up, the central air conditioning was stopped. In fact, the central air supply for the air circulation, because we all look at hand hygiene, etc. But when you start looking at the AC ducts, Again, a very big source of infection. So central ACs were stopped, local ACs were put in. How to create a negative room was a challenge. So nobody put a HEPA filters, though we did talk about it, but we tried to put then the large functional, exhaust fans. So that's what we started doing it. And then with our nurses who are there, and very good nurses, and I have a immense faith, and we empowered them. It's not that only having nurses is important or the people trained is important. Empowering is important so that they can have some amount of role where they can discipline you. Otherwise, nobody listens to them, and especially the big doctors. They don't listen to them. So that's what we did. We empowered them. Then we started practicing how one will come, how will one will go, because the people started asking us, okay, you should have a separate outcomes. So to coming in a functional hospital, and when you don't have a separate, we were running both COVID and non-COVID services. So it had become far more bigger challenge. If you're a COVID service, there is no issue. One place entry, one place exit. Then besides hand hygiene, air hygiene practices, so ICUs were fixed up with the either your window ACs or with the other air conditioner, because otherwise in the sweltering heat, it was very difficult to work with those PPEs. Then subsequently, obviously, aerosol, we went with it, N95 mask. How to go ahead with N95 mask already should little bit eased us for us, because there's so much panic that you can use that for 5 days. So we used to issue 5 N95. That was first challenge for the first 4 to 5, 6 months. But when the thing started, we became liberal with it. So used it with a surgical mask. And remember that the cost of the surgical mask has gone up to 40 rupees, and the N95, which was, we got it up to 160 rupees, but gradually it all came down, and you know what the cost actually are. So there were the few things which we had in. We tried different experimentations, and then when we started realizing it, we also put some amount of a barrier on the use of antibiotics. Why you will see, because we realized that consistently after some few cases, that primarily it's a viral infection, there is no need to unnecessary. So we put some amount of a barrier or a check that up to what level residents will do it. And that's what we went ahead with it. And finally, when you started looking how to dispose of the biomedical waste, that was as important. Cleaning of the surfaces up and down, and how will you use your sanitizing practices. So we shifted from the conventional formalin to the bacilloid and other chemicals for the cleansing. And then we also went on a lot of floor washing, etc., giving gum boots, etc. So we try to do a 360 thing, and then along with it, we created for the people when they're going out of the duty, so that they don't carry the infection, the new bathrooms where they can wash. Similarly, created the extra facilities. Sometimes people have difficulty, and especially with the ladies, we found out, which was something unusual, was an increase in the higher incidence of UTIs coming up in the nurses, because they were holding it up and other problems. So we tried to look at it, and once they got out of it, then the linen, how you will handle the linen, because the laundry refused to take it out. So they said, we will not do it. So we first, as I said it earlier, we tried to chemically disinfect it, but it damaged a lot of linen. Then we sent it to the sterilization in the closed barrows, and then finally from there going for cleansing, washing, coming back, using it up. Later on, gradually we started getting a lot of disposable gowns, but it created another problem of their disposing biomedical waste. So one problem you think you have solved, it led to other one. And then finally, I don't know whether I should call it an IPC practice or it was more of an administrative practice. Large number of your staff, we had to create, when they were on duty before quarantine, to have a separate quarters for their stay, so that they don't carry the infection. In particular, it was a challenge. I don't know whether to call it an infection control, whether it was a part of it, but primarily it was not to carry the infection at home. So we worked at multiple places. We worked it at teaching, we worked it at training, we worked it at capacity building, we worked it at creating new infrastructure, we also creating new guidelines, and then we did the auditing of it, whether it is being held or not. And when we looked at on our WHO scale, still we're doing this, we are only coming up to 76% of what which has now been in the public domain, we have published it. So it has been Devaju, it has been a roller skater ride, learning, and we kept on learning whatever the theory is there. But I have realized only one thing we need to put practice as a policy in this country is auditing. But auditing must not be used to point fingers. Then people don't speak. I think this is what we have learned over a period of time. And you will be surprised to know that once we started putting a check, because we realized that infection control within the closed four walls of ICUs are difficult because not many people are willing to go. And when I see, if you really ask me, it reminded sometimes you of the nightmares of the horror movies. I'm not exaggerating at that, because we were the frontliners. We were going inside, looking at it. 2 nurses looking after 8 patients, everybody breathless, how they are going up. It was a nightmare actually. And it has been extremely traumatic. We all talk about the family and attendant. Same thing was bringing up the morale of the people who are working there was a big challenge. Because without them, whatever we talk, it's all theory. But nevertheless, when we worked together, we led from the front, we created leadership, we empowered them, we were able to do it subsequently. And I can say with a sense of pride that our mortality rate exponentially decreased once we were able to put the different protocols. And we used a lot of biomarkers in terms of taking decisions in terms of antibiotics. And we checked it up, put a hold. So that did make a lot of difference. That's how we went ahead in the COVID in a nutshell.
Right. Thank you so much, Dr. Dhruv. While whatever you talked about for us, while it was a hard reality for you and everyone, around you, it was a lived reality. And I have a follow-up question for you, but I'll just come back to you, circle back to you just in a minute. We have now with us the Director General Health Services here with us. So, Dr. Atul Goel.
Yeah, good evening.
Yeah, good afternoon, sir. So over to you for
your
remarks.
3:30 afternoon or evening, that's up to you, no issue. I'm very happy to be here. And I was listening quietly to Dr. Dhruv. It was a wonderful lecture.
Thank you so much, sir, for joining us today. And while we have started the session panel discussion here today, but it'll be great to hear from you about this growing concern about antimicrobial resistance and how IPC has come into picture, and especially post-COVID we have been seeing the need for more strengthened solutions and actions on this particular area. And also, if you could help us understand how the government is thinking and what can we expect in the near future, and how constructively all of us as diverse stakeholder groups can come together and work in this space. Over to you, sir.
Yes, definitely. I would. You can hear me?
Absolutely, sir. You're audible.
So I would go back a little bit into the history of antibiotics and maybe take it from there. The discovery of penicillins that occurred in 1920s was a breakthrough. That was the breakthrough which actually probably took us on the path of antimicrobial antibiotics, although penicillins were not the first drugs to be used. So the first drugs which were used as antimicrobials was something called Prontocel, which had a agent called sulfanilamide, which was used for the first time in Germany during and immediately after World War I. Thereafter, penicillin was used sometime in the 40s, 1946 to be precise, and it was a wonder drug. I believe it still is, although the so-called newer antimicrobials have pushed it way behind. Before I go on to the real part of antimicrobial resistance, I would ponder a little bit and speak about the human race. Human race has a peculiar quality. First, it creates problems by way of the so-called development, when people understand as development, say for example, newer antibiotics. And thereafter, we try to find solutions, as we are here together to find the solutions to antimicrobial resistance. Well, I have no doubt that we have created it also. So, scientific bodies around the world talk of science and being scientific in its approach. But whenever there is an emergency, there was the so-called COVID emergency in the last 2 years. The so-called scientific bodies are the first ones to give up on the scientific method completely. And I say COVID was one such example, with emergency approval given to one drug after another. For COVID, it was hydroxychloroquine, then ivermectin, and then doxycycline, then azithromycin, remdesivir, human plasma, monoclonal antibodies. What all can I not speak about? And knowing fully well that COVID was a viral infection and viral infections are self-limiting. So, well, it was a purely non-scientific approach. Now, the major and the real reason and the only reason for AMR to my mind is, well, greed I would classify into two aspects. One of the certain sections of the pharmaceutical industry which have been irresponsible, and also certain of the users who have the power of prescribing being irresponsible. Now, whenever a new molecule is discovered, the introduction to the doctors, introduction to the hospitals, introduction to the medical setup is about maximal use. It should be the other way around. It should be restricted. It should be limited to whenever it was required. Similarly, coming to prescriptions, we all know as doctors that most conditions humans face as infective to begin with do not require any antibiotics, any antimicrobials. However, we are using it. They are being used. Whether you talk of upper respiratory infections, whether you talk of diarrheas, whether you talk of viral fevers, there is an indiscriminate prescription of antibiotics which is being done, which has to be stopped by our own community. It has to be stopped by my colleagues. So perhaps there only one thing to take care of antimicrobial resistance or so-called AMR is responsible behavior by the pharmaceutical industry and a responsible use by human beings, both medical fraternity and laymen. Today, public is using antibiotics as over-the-counter drugs. They are being given by chemists. So somewhere down we have to stop this use. I will share few instances of misuse. Without offending anyone in the private sector, there is sometimes a mindless change in the antibiotics in the private sector and to an extent in the government sector today. A sick patient is admitted in the ICU. First day, one antibiotic, the patient does not respond. Second antibiotic is introduced. So by the time the patient is there for 5-6 days, he gets a mindless combination of 4 to 5, 5 to 6 antibiotics. So that's our behavior. We need to modify it. Similarly, beginning of advanced antibiotics where basic would have been effective simply because the patient is sick, simply because the patient is a little too sick to satisfy the relatives or to satisfy whatever. I don't understand why we should be using something like meropenem when a lesser known antibiotic could be effective. So penicillin is one classical example. When I was intern or I was a house surgeon, it was the drug of choice for meningitis, for meningococcemia, and I think it still is. It still is. The only problem that used to occur at that time was that it needed to be administered 2 to 4 hourly. So perhaps the pharmaceutical industry could have been responsible in finding ways where the pharmacokinetics of penicillin could be added rather than removing penicillin completely from the armamentarium. So I only hope that we are already not too late in initiating action in this regard. But in the fact that we may be late, hope is actually something which we bank upon. And the comeback of doxycycline or tetracyclines is perhaps the silver lining. Therefore, it is imperative to restrict the use of antibiotic in the hands of medical fraternity, responsibility of World Health bodies and pharmaceutical industry to try and work on antimicrobial resistance. I must end by enumerating the risks of antibiotic use apart from just AMR. AMR is just one of them. One is alteration of the human microbiome in our on our body surfaces and in our body cavities, whether we talk of mouth, pharynx, or intestines and skin, which this human microbiome plays a vital role in protection against a variety of disease processes, not just infections. Similarly, fungal growth by inhibiting commensal bacteria, The so-called mucormycosis or black fungus was a case in point. There was a mindless self-medication with steam, antibiotics, and even inhaled steroids for prevention of a disease, which led to the development of mucormycosis rather than blame it on, say, poor quality of oxygen and various things.
Right.
I say clear and loudly, every chemical, this is the third point, whether it is in food, drink, or used as a drug, is potentially harmful if used without need. Which means, why the need of exposing oneself to necessity? Potentially, they can be toxic to our organ systems, especially liver and kidney, besides producing allergic reactions. Now, to end, I would just say one thing, that I have not used antibiotics personally for the last 25 years on myself. And I minimize the use of antibiotics on my patients unless they're absolutely required. I would not use them. Thank you so much for a patient hearing.
Thank you so much, sir. I think first of all, thank you for giving us this broad overview of the issue that we have at hand, and the last line that you said, I think we cannot go more conscious on whatever we are talking about today, more than what you've just gave as a closing remark. But just before we proceed, one question to you, that we have been talking about solutions, we have been talking about also everything in the context of COVID, and how important now it is to also empower the nurses, protect the nurses, and bring more solutions. So how do you think that the platform for training the nurses would also contribute more positively in this regard that we are talking here today?
You see, everyone requires training. Everyone requires training, but somehow the trainings today are ignoring the practical aspect of it. You don't get trained by passing theory exams.
Yeah.
You don't get trained by you get trained by actually driving on the road. Nobody learns driving by reading books. So you have to drive on the road. So you have to see, today nursing students, for that matter, they don't attend to practical wards training, which is decreased completely. So I was hearing the other way in a discussion at DGHS, where it was told to me that nurses who finish BSc training cannot handle taking deliveries. They are not trained for taking deliveries. I learned my delivery taking in a labor room at Subdivision Hospital from one of the senior nurses. So the fault lies with the system, and nobody makes a system except us. We have put too much effort in terms of theory in developing curricula, but we are not seeing whether those curricula are practically being used or practiced at the field level.
Right.
So training would help, but training has to be practical. It hasn't to be theoretical. It hasn't to be through webinars or classes. It has to be on the field.
Absolutely. I think so. We couldn't agree more, with whatever you've said. And now I hand over, to Mr. Sharad Goswami to give a vote of thanks to
in fact, when
Dr.
Mr. Sharad met me in the directorate, I told him that I am going to speak my mind. I'm not going to mince words when I come to this webinar. So he said, we have no hassles, and I'm glad I could speak my mind. Thank you.
Dr. So your views are welcome. Very
Just
much
a
welcome.
minute.
Sorry.
I to see good old friend, our Dr. Atul Goyal. It's such a long time, but it's nice to see that he's at a DGHS with the physician, is going to make lots of change at the clinician sitting there. And all the best of luck to you, Dr. Atul.
Thank you so much, Dr. Dhruv. I would like able to make a change, and I'll definitely try to.
Yeah.
Thank you everyone. DGHS sir, it was good to meet you the other day, and this is exactly what we agreed, that you would speak your mind and you would call out the issues as they are, and we are very, very grateful that you did. We just want to assure you that the intent really here is exactly the same. I think we are all on the same page. We have to preserve what we have because we know there are very few available. And whatever we can do to preserve what we have, which includes preventing infections to the extent that we can, which includes reducing consumption of antimicrobials as much as we can, which includes rational use, which includes raising awareness and making sure that there is no dispensing of these vital drugs without due prescription, which includes creating and helping create IPC infrastructure. All of these are aspects that we are all very deeply invested in. And we look forward to your partnership and your guidance, as we do to all the experts who are together thinking about this issue and working on this issue and helping move things in the right direction. So I want to thank you for your candid views, and I hope that you will continue to be this candid and lead this policy making in the direction of curbing the impact of AMR. With that, I thank you. I thank all our panelists for your time today in this first panel discussion.
Thank you so much.
Thank you so much, Mr. Sharad. And again, a big thank you to Dr. Atul Goel for being here with us and
your
sharing.
Permission to leave now. I have another meeting. So
Sure, sir. Thank you so much for being here. It was a pleasure having you. Yeah. So while we have overshot the time a little, I would just circle back to our panelists just for, maybe one crisp last, closing remarks from all of you. Dr. Dhruv, we would start from you, a brief closing remark from you, given we have the paucity of time, sir.
Yeah, absolutely sure. I think what Dr. Atul said is important, and everything starts from home. So let's make empowered, as I said it, we need to have infection control practices in place. Secondly, we need to not to know that anybody comes in, like now NMC is coming up with a policy. So probably it's a 24/7 job which we need to keep on practicing and probably be a part of our habit. Only then we will be able to do it. But nevertheless, as an administrator, I will say we need to keep on auditing our practices regularly. What he was also saying, Atul, that we need to look at it, what we are training is it being translated on the ground or not. So I think that's with these things, so probably self-discipline, self-motivation, 2, empowerment of your nurses and paramedical staff, and probably following evidence-based practices, and at the same time ensuring hand hygiene is being practiced, if nothing else, across the board, and auditing and rechecking, only the way forward.
Thank you so much, Dr. Dhruv. Dr. George, over to you. One brief closing remark from you on this.
Thank you very much. As I told earlier and now also, that the infection control practices has to be not to be discussed in the meetings, not only to be discussed in the meeting, it has to be implemented on ground by empowering the infection control committee as well as continuous training of all the healthcare team members to ensure that it is being practiced. That's very important. And of course, not only theory, the practical aspect has to be taken care, and practice has to be. That's okay.
Thank you so much, Dr. George and Dr. Rahul. Not last but not at all the least, so closing remarks from you over everything that we've discussed today.
For an effective infection control as well as antimicrobial stewardship, we need a strong structure, process, and outcome measurement. A strong structure in form of strong SOPs, policies, and procedures in place. A strong process means a stringent compliance towards the implementation of infection control measures and antimicrobial stewardship. And strong output means a regular risk assessment at regular intervals for assessing our interventions of our IPs and AMS. Last but not least, knowledge forms a key tool for improving adherence towards the infection control stewardship.
Thank you so much, Dr. Rahul. And this was a very interesting and intriguing discussion, first round of discussion. And here we move to session 2. I first request Anisha Dhawan, who is the comparer today for the session. So if you could just come in and help us in introducing the next panel of speakers that we have. Thank you so much.
Thank you. Thank you so much to all our speakers for joining us, and thank you, Dr. Nandi, for conducting such a great discussion. I now have the pleasure to introduce our next set of guests who are joining us to discuss another important issue. And the issue that we're going to discuss this time is the impact of COVID-19 pandemic on surveillance and stewardship. I would like to invite our experts on the panel. Please welcome Dr. Subramaniam Swaminathan, Director, Infectious Diseases and Infection Control, Gleneagles Global Hospital, Chennai. Please also welcome Dr. Sujit J. Chandi, Professor, Department of Pharmacology and Clinical Pharmacology, Christian Medical College, Vellore. Please welcome Dr. Grace Mary John, HOD, Clinical Pharmacy, Infectious Disease Clinical Specialist, Believers Church Medical College Hospital, Kerala. Please also welcome Dr. Kamini Walia, Scientist F, Program of the AMR Division of Epidemiology and Communication Diseases, Indian Council of Medical Research, New Delhi. Please welcome Dr. Tim James, Head of Drug Resistant Infection Program, Wellcome Trust, Dr. Camelia Rodriguez, Consultant Microbiologist, Chairperson, Infection Control Committee, PD Hinduja Hospital and Medical Research Center, Mumbai, and Dr. Shonali Dige, Senior Director, Medical Affairs, Fizer India. And of course, to moderate this discussion, I'll hand it back to Dr. Nalini Kaushik, Principal Consultant, Policy Advocacy and Government Affairs, ISW Council.
Thank you so much, Anisha, for helping introduce all our panelists. And I think I see some very senior and some very important, experts with us today. I think it's a pleasure to be talking with all of you today here. Again, since we are talking, in the context of AMR, and this entire discussion is around, COVID-19 pandemic and impact on surveillance and stewardship. I would begin with Dr. Swaminathan. So thank you so much, first of all, for being here with us. We would, let us just, briefly, again, contextualize the entire conversation so that, we can move towards a more deeper and advanced discussion today. So let's start from the basics, AMS. What is it? How does it, how the AMS practice is beneficial for patients, doctors, and the hospitals?
So AMS, basically, to me, it means using antimicrobials in a responsible way to ensure the best outcomes and minimizing collateral damage and possibly reducing cost, both in the short term and in the long term. So for the patient, what are the benefits? Obviously, having an AMS guided empiric therapy helps in multiple ways. Simple example, when you have a patient in septic shock and a severe infection, starting the right dose of the right antibiotic is probably one of the most important measures in reducing mortality. That's a simple example of how AMS can make a huge difference. Also, that we can cut antibiotic duration significantly. Now, more and more studies are supporting that, which basically means patients are stuck in hospitals for a lot shorter period of time and probably have less complications as well. And there are some studies, at least small ones, which are trending to suggest less problems with shorter duration antibiotics. So obviously there are some multiple wins over here. For the hospital, it's a good thing because having better outcomes basically means it's a good reputation for the hospital. And also that more and more hospitals are offering packages for various elective procedures and things like that. So having a good AMS program could probably limit the expenses that they have on the antimicrobial side. That's just one small part of it. And there are various other hidden benefits that they could have. And overall for the society, I think that's been discussed in great detail. So I think that's good. But for the doctors, simply put, I think AMS is one way of improving outcomes while keeping costs down. Because ultimately, honestly, if you look at the current healthcare paradigm, hospital bills automatically become the mistake of the doctor, not the hospital. That's just the way it is. So if we can improve outcomes and reduce costs, I think doctors can sleep better at night.
Right. Thank you so much, sir. And I think as simple the question it sounded from my side, I think the answer was quite complex. And I think you very simplistically helped us understand the entire, the scenario on that front. And I think whatever you've said, I think one thing that emerges is, the role of pharmacists. And I think I would move on to Dr. Sujit here and Dr. Grace Mary, who are both, from a similar background and, their role as a pharmacist becomes really important, when we talk about AMS here today. So Dr. Sujit, I'm going to begin with you and then follow up with Dr. Grace that, if we understand, from the pharmacist perspective, what is the role of a clinical pharmacist when it comes to, when we have to effectively implement AMS practices?
Thanks very much for the question. I think Grace would be the best person to answer it because she's the pharmacist and I'm not. But nevertheless, I do have a related field. So let me just broaden it a bit. If you look at the body, each organ has multiple functions and each has its own role. And if you look at infections per se or beyond, as we looked at what happened in COVID, there were multiple facets. It was not just about the virus. It was about livelihood. It was about how hospitals coped and strategized. So again, there are multiple roles within the system. So similarly, when you have an organism moving in and causing an infection, it's not just about the drug. It's also about infection control. It's about other things in terms of hygiene, etc. So when we talk about how to combat it, I think a multidisciplinary role is very important. Of course, we often simplistically look at what we're discussing in terms of a very good hospital, and therefore you would have a clinical pharmacist, or you would have X number of different roles. Sometimes it's a primary level care hospital where you don't have any of them. So, but since you've asked about the clinical pharmacist, let me just move on to that, thinking of it as a tertiary care center, for example, or wherever there is a clinical pharmacist. And I think the role here is that we need to realize that most of our hospitals are overburdened, and it is very difficult for one occupation or one profession, in this case, for example, the doctor, to handle everything. We also need to realize that the medicine is a peculiar thing. Medicines are not just for healing, but they also have safety issues. They also have 3 steps, if I can put it that way. You have the prescription, you have the administration, and you also have the dispensation, all by 3 different professions within the same place. So therefore, when a medicine is actually given, in this case the antibiotic, to a patient, you've got lots of factors coming into play. It could be the dosing, it could be what the choice of the antibiotic, it could be drug interactions, it could be side effects, and of course we've got this overarching umbrella issue of antimicrobial resistance. So whatever Dr. Subramaniam said in terms of AMRs then kicks into play as to how does one make the choice, how does one decide on the dose, how does one even decide on just a simple thing like duration, where there are multiple studies saying different things. So I think the doctor can manage, but then when you have a complex situation with so many different patients, you do need that extra help. And that's that complementary role is often played in many places by the clinical pharmacist, looking very much into dosing issues, the kinetics part, for example. It could be a MIC issue, which the microbiology lab will then give as a report and that interpretation. It could even be a simple thing as informing the patient, yes, look, it's good to have an antibiotic, you do need it, or you don't need it because actually it's a viral infection, but also about the fact, a little bit of health education, and what is an antibiotic, and as Dr. Atul said in the previous session, about the microbiome, what it actually does to your body if you take it unnecessarily. So I think, therefore, that complementary action by the clinical pharmacist is crucial, and we in India need to move forward. Already hospitals have started with that, but I think it's going to be a real game changer when we involve the multidisciplinary approach into antibiotic stewardship. Thank you.
Absolutely, absolutely. Thank you so much, Dr. Sajid. And I think whatever you've said, I think on one hand, I mean, from where I see is that we have patients who are in hospital, under, guidance of doctors, and how do we, administer doses there? And that is one. 2 is, the population at large, and where the question of rational use of, medicines also comes into play. Quickly, your thoughts on this other side of the spectrum as well, and where do you think, like, we do have guidelines, we have, all the guidelines regulating the OTC, the counter sale of drugs, etc. But what do you think, where are we, and where do we need to, strengthen our, systems over on that front as well?
Yeah, there are different types of guidelines. We have national guidelines, we have state guidelines, we have hospital guidelines. Now, of course, there has to be some set of guidelines because people need a benchmark or a standard and a flow process, if I can put it that way. Especially, there are many regions where they really have no access to information. And we have to think of them also. But within a hospital, I think if you really need the guidelines to work, it should be a community level participation into the guidelines and not just a top-down approach. Each department has its own issues. Each specialty has its own difficulties with infections and their own apprehensions if they don't give an antibiotic. So I just very briefly say that we had a situation in CMC Vellore in 2000, and Dr. Subramaniam was there at that point, where we actually brought in departments together, discussed with them over weeks about the guidelines, and we then managed to get a guideline in which people believed it. Right? So that they then are able to implement it and practice it. Nevertheless, we had our challenges, but I think it really helped improve implementation. And I think that is the real trick in this. Thank you.
Thank you so much, Dr. Sujit. And Dr. Grace, I'm going to ask almost a similar question to you, but an understanding from your perspective, from a pharmacist perspective, that firstly, what is the role of a clinical pharmacist when we talk about effective implementation of AMS, which is a very critical component of our health systems today?
Thank you, Dr. Nalini, for your question. I would like to say that when you ask about the role of a clinical pharmacist in stewardship, already it has been touched upon by Dr. Sujit and Dr. Subramaniam there already. And it starts right from the implementation of policies like servicing. And Icmr has done such a wonderful job in bringing out the national antimicrobial policy so that it's easy for us to adapt our Indian guidelines rather than going after the IDSA guidelines or things like that, because our population is very different from theirs. So we start off with, maybe the implementation of developing of the antibiogram initially. So I myself helped with the antibiogram, the bringing out of the antibiogram and the institutional antimicrobial policy. And that is the first part of it. And when it comes to the actual implementation of AMS, that's where the whole energy comes in. So if you see at the CDC has revised its 2019 in its 2019 guidelines, the core elements of antimicrobial stewardship, and they have revised it when it comes to the leadership, as to who should own, who should be the steward for a stewardship program. They are now saying it's either the ID trained physician or an ID trained pharmacist who can lead the AMSP. So why is it there's so much importance for a pharmacist there? Because running or implementing the antimicrobial stewardship, if you again go into the CDC, they say that the parameters that we can do, or the processes that we can do, includes the pre-authorization, the clinical audits, the prospective feedback. So all these things, it requires so much of manpower. So, and if you look at any of the sustainable, successful antimicrobial stewardship programs in India, you will see that the backbone of the workforce for the such stewardship programs are going to be the clinical pharmacist, because who is going to the bedside to clinically correlate the blood culture or the whatever culture reports that you have at hand, who is going to see the reserve antimicrobial that has been prescribed to the patient is actually whether it's rational or not. So the prospective audit takes a lot of time. It requires a lot of manpower. Therefore, that is one major thing that we do. Along with that comes the de-escalation, the escalations. And also one thing I really noticed is that the need for bundles, when we say cutting the duration of antibiotics, that is actually in a way a double-edged sword, because when it comes to an MRSA bacteremia or a candidemia kind of thing, people tend to cut off the antibiotics after 7 days or 8 days, like they normally do for the other infections. But, such bundles, documenting the negative culture, making sure 14 days of IV therapy is given for these patients, all these things are followed up by the clinical pharmacist. And most importantly, the thing I would like to mention here is, as a role of clinical pharmacists in stewardship, is that for all of us to have a sustainable antimicrobial stewardship, the administration has to support us. So for the administration to support, we have to show them that it's successful. So how do we show that it's successful? We have to bring in the measures, bring in the parameters like the process measure, Dr. Rahul was saying, the outcome measures, so the percentage of compliance with the surgical prophylaxis, percentage of compliance with the antimicrobial policy, the percentage of de-escalations, escalation, all these things. And the major thing that WHO and CDC, they stress upon, so that the benchmarking is same throughout the other hospitals, like the defined daily doses calculation, the days of therapy kind of calculations, where you can see, okay, hospital A is doing this, hospital B is doing this. Who is going to compute all these data? This is where I think clinical pharmacists come in a big way, because we need, you need that power, you need those stewards to work the stewardship and make it a successful and a sustainable program.
Thank you so much, Dr. Grace. And I think if we just combine what we have heard so far from Dr. Subramanian, from Dr. Sujit, and from Dr. Grace, I think we cannot really stress more on the role of a clinical pharmacist when we have to really resolve, the problem from, when we have to nip the problem in the bud. I think we cannot, think in isolation, but involve the clinical pharmacist and understand the critical role that they play. So moving forward, we have with us Dr. Kamini Walia. Thank you so much, ma'am. We all know that the kind of work that you've been doing in the last few years, in your capacity in addressing the concern of AMR and the various dimensions associated with it. We have been also, I think since in the panel 1 and now in the panel 2 as well, we've been trying to understand, solutions as well. We have been talking about the problems, but we need to be more solution oriented. So if we could just understand, we can get a quick overview from you about the Icmr Fizer program, the collaboration that we have, and what have been the key learnings and the challenges and the highlights, and what have been like, how can we move forward from there?
Yeah.
Over to you, ma'am.
Thank you. Thanks, Nalini, for inviting me to this very important panel. And it is good to have so many colleagues who have been working with us under the Icmr program as well as part of the panel. So I think the overall aim of this panel is to understand, what all we can do to expedite AMR containment in our country. And we have heard in the previous session also the emphasis on the infection prevention and the control practices. And over here, we are discussing more on what are how the AMSP can be useful in containment of AMR. But one thing we all have to understand is that antimicrobial stewardship cannot stand on its own. It needs to be supported by the diagnostic stewardship as well as the infection prevention and control. And we have already discussed some of it in the last session, so I will not repeat that. But the overall aim should be to reduce the number of opportunities which will require antibiotic administration, and also to improve the specificity of the treatment as much as we can. So to answer your question on the Icmr Fizer collaboration, I would like to step back a bit and talk more about the Icmr Initiative on AMR, which actually laid the foundation for the Icmr Fizer project. So this initiative started about 10 years back when we put together the first national AMR surveillance network. The idea was to strengthen research and evidence on understanding the trend and the pattern and the clonality of the bugs which we commonly come across in our hospitals and which cause drug-resistant infections. So we have a three-pronged initiative which looks at the AMR surveillance, which looks at promoting the better practices around infection control, and also in 2018 we launched the Anti-Microbial Stewardship program. So as surveillance continued, we were able to get better understanding of what are the yearly trends and the patterns of AMR in our country. And this report we put out every year on Icmr website, anyone can look at it. And we also try to describe the mechanism of resistance which are prevalent in our country. Added to that was a big project on hospital-acquired infection surveillance, and there are 30 tertiary care hospitals who are now part of this particular program. But one thing which we found was exceptionally high levels of resistance, whether it was in Delhi or Hinduja or PGI Chandigarh, very high levels of resistance which were hard to believe. So then we realized that the patients are coming after multiple treatments, multiple antibiotic failures. So if we really want to address the challenge of AMR in our country, we have to move beyond the tertiary care. And that's what actually, laid foundation of the bigger initiative that we are doing with Fizer. The two things Dr. Grace mentioned in her comments, she talked about the CDC guidelines changing to ID physicians or including pharmacists. But I don't want to sound like a devil's advocate, but the fact is that Indian hospitals have none. Many hospitals, they neither have ID physicians nor do they have clinical pharmacists. And this was a very good awakening for us also when we were putting together the AMSP program. Who's going to lead this initiative? So for our country settings, what we advocate and say is that any clinician, whether he's a internal medicine clinician or an intensivist or even a surgeon, if he feels passionate or she feels passionate about AMR, he or she can lead the AMR initiative in their hospital, and with a little bit of training around ID and antimicrobial stewardship, because we are at such a stage we can't afford to delay it anymore. We can't be waiting for the super specialists to take on this initiative in their hospital. But the pharmacists we definitely provided to these tertiary care hospitals as a part of project staff, because we wanted to make the hospital understand the value of having a pharmacist in their hospital. And the outcome of that was that Hinduja and Gangaram Hospital, two hospitals, actually created a permanent post for a clinical pharmacist just for antimicrobial stewardship in their hospitals. In government hospitals, these changes are slow to come by, but I'm sure, once the point gets across, these changes will also come forward. Now coming to the Icmr fizer project, as I said, we realized that if we really want to address things at the root, we need to go beyond the tertiary care, we need to go to the secondary hospitals, we need to go to the nursing homes, we need to go to the district hospitals, because that's sometimes the first point of treatment or any surgical intervention, and sometimes when things fail there, they end up in the tertiary care hospital after multiple antibiotic treatments. So we decided to expand the footprint of Icmr Initiative beyond the tertiary to the secondary level hospitals and the nursing homes. And we selected few of the hospitals from Icmr network to act as mentoring centers and pick up at least 8 to 10 hospitals, nursing homes and district hospitals in their area for mentoring. So I'm quite happy to report that we are now working with 90 more district hospitals and nursing homes in the country, and the footprint is definitely expanding. It is challenging to work with these hospitals many a times because they have limited staff. Sometimes the staff is not able to spare time for these trainings. And also, the laboratories are a major challenge because you cannot have AMS in absence of a good diagnostic lab, and the labs are not there. Even if the labs are there, the full-time microbiologist is not there. So there are some cities where not even a single accredited lab is there. So we are in the process of identifying those gaps, and the overall aim is to help them plug those gaps. It is a long process, but now we have been working with them for almost a year and a half. We had planned to start early, but as everyone knows, there was COVID pandemic and it was a serious setback to our project. But now everything is on the track, and but these changes are very slow to come by. Initially, there was not very good trust between the mentoring centers and the hospitals that they were trying to mentor. It was a very challenging situation. So for many of such sensitization workshops, I have requested that, we from Icmr, this project is being done. So, but then it is also good to see that most hospitals are taking IPC more seriously. There is a structure and framework for implementing infection control. But then antimicrobial stewardship is something which is being ignored. Even in the government hospitals, because there is so much focus from government in many, through many schemes like the Kayakal program, biomedical waste management programs are there, especially after COVID. So I would say things on the IPC side are looking brighter, and we will, kind of gain more ground working on the IPC side more quickly as compared to antimicrobial stewardship, which requires everything from human resource, capacity building, to education around antimicrobial stewardship. So, it is a work in progress, and I think every few months or a year we should take stock of how far we have traveled and, feel good, feel motivated about it. But the progress, I would say, has been better than what we had expected. So that's a brighter side of it. Thank you.
Thank you. Thank you so much, Dr. Kamini. I think with whatever you've said, I think it's quite intriguing because it showed one side, which is, the gravity of the problem that we have. But at the same time, I think it's really commendable to see how the government is really motivated to bring solutions, and also taking solutions, below the pyramid in a very decentralized solutions, because we know that the problem is situated at various levels, and until and unless we do not decentralize the solutions, I think we would be failing, at a massive level. So I think it's really incredible to see and to hear the kind of work you along with your organizations you are doing. Moving forward, I would like to bring in Dr. Tim Jinks. He is the head of infectious diseases interventions at Wellcome Trust. Thank you so much, Dr. Tim, for being here and for sparing your time and being here with us. You've been hearing to all our, panelists and experts here today on this particular issue. You represent and you've had this great experience of, the global community or global public health community, seeing a lot of, situations, health situations, and the most recent one, COVID-19 pandemic. How do you think that, that the pandemic also, fueled the AMR global health crisis that we have, with us? And what could be a global response to the same?
Thank you very much for inviting me to participate in this panel. And the subject that's being covered here is incredibly important. And the question you put to me is one that it's a bit of a tough one because the way the impact of COVID-19 on AMR and the AMR crisis, we do not really know the full impact at this point in time. Because of the nature of AMR, it's a slow-moving pandemic. And so the read-through of the impact of COVID-19 has not yet really become clear to us in the evidence of things to see what's happening with patients and particularly in communities as well. But we do know that there have been some very serious issues that have arisen during the COVID-19 pandemic that will be fueling the AMR crisis and driving it forward. For example, in the area with respect to the COVID-19 patients themselves, at this point in time, there is a much better treatment and patient management guidelines, which does involve a reduced level of antibiotic prescribing, but nonetheless, the level of nosocomial and secondary bacterial infections and superinfections in the hospitalized COVID-19 patients is very, very high. And the evidence is showing globally that AMR in those patients is at a higher level and one that is looking like it may be increasing, and particularly for some pathogens where we thought we might have had some better control. For example, in Staph aureus, we are seeing an increase in drug-resistant Staph aureus appearing in these patients. That's very concerning to have that happen. Also, in the COVID-19 patients, many of them have prolonged treatment in hospitals, and that is an increased factor for gaining these infections and having these infections passed on to others. So that is one area directly associated with COVID-19 patients where we are seeing that there is a fueling of AMR. Alongside of that is the inappropriate prescribing and overuse of antimicrobials. It's a bit of a mixed picture here. Early on in the pandemic, it was frankly terrible. There was tremendous overuse of antibiotics, but we have seen that that's tapered off. And in fact, today it's looking very promising that there is a reduced level of antibiotic prescribing for patients because the focus is much more on treating people who have a viral disease. And so, it's possibly going to turn out very different than we might expect here, though there was a period of very clear high levels of antibiotic prescribing and overuse. Maybe we will have moved to a better steady state position where there is a lower level of inappropriate prescribing. Alongside that, particularly in the healthcare settings, been the increased use of biocides as the necessary improved infection prevention and control measures. We don't know the impact of that in terms of selecting for resistance, but it could be a factor that is fueling for additional resistance. But most importantly, I believe, is thinking about the impact of the compromises that have been had in healthcare systems overall. And there are two areas that are hugely important that we're concerned about at Wellcome. That's related to the antibiotic stewardship programs as well as surveillance programs. And what we saw are that these activities were often curtailed or stopped entirely because of the necessary redeployment of staff and resources to focus on the most urgent needs of dealing with COVID-19 overall. It is unclear how well the healthcare systems globally are actually adapting to a new normal. And so are the antimicrobial stewardships programs actually being put back together to get back to the stage they were at, which wasn't as good as it should be, but still, are we even back to where we were before the pandemic hit? I think that's very unlikely, and the consequences of that is very obvious. Similarly, on surveillance, we are going into a situation where there was insufficient surveillance globally, but we were starting to have a better picture with new surveillance programs coming on and access to data in new ways. We're going to have a bit of a blind spot, I think, as a result of the pandemic. And of course, if you don't have the information and provide the evidence, then it becomes difficult for deploying the resources in the best possible way. So both of these factors are likely to be very major drivers in the setting of hospitalized care. We do not know what the situation is in the communities. There was insufficient evidence really even before COVID-19 about the drivers of AMR in communities and actually the community carriage rate. But that very low level of understanding that we had before COVID-19 is now going into something that's pretty much non-existent. But it's a one where there's a bit of a natural experiment facing the world in this, because COVID-19 changed how healthcare systems work. It also changed people's behaviors in healthcare seeking. And so we actually had fewer people globally coming into healthcare systems for many treatments that previously they would have had, and those that the sorts of infections where AMR is particularly problematic. So we don't know yet whether or not AMR in the community has increased as a result of people not receiving appropriate care, or if in fact it's at some sort of steady state or decreased in some ways because people are not being treated inappropriately, which is one of the big problems that we've seen in the past. So it's a very mixed picture, but there are those kind of four broad elements that we know will be fueling AMR overall. It's the patients, the COVID-19 patients themselves, how they're treated, the inappropriate prescribing that has happened, but hopefully now we're in a much better place. IPC, biocides, which chemically drive it, but lastly, that part on the reduction of the antimicrobial stewardship programs and surveillance. So I'm going to shout out again that we really need to make sure that those are reinvigorated and pushed forward to be built out further.
Absolutely. Thank you so much, Dr. Kim. And I think, first of all, thank you for giving us that broad overview. And then we understand that EMS and surveillance become so critical when we talk about global health emergencies. And, you know, health systems are very dynamic. And we are surrounded by situations and, you know, maybe future situations which could be, you know, as grave as what we have, you know, seen in the recent past. So I think we need to, when it comes to, you know, from the aspects of preparedness, I think it's really important to focus on EMS and surveillance, that such practices are not compromised, because that's where strengthening part of the health system is also concerned. Thank you so much for your inputs, and I would like Dr. Camilla to come in now. Thank you so much, ma'am, for joining us today. Again, we have been, talking back and forth from various perspectives about, strengthening AMR surveillance in hospitals. Sometimes, like we are talking about the global practices, we are talking about how pharmacists can support what the government under ICMR, through ICMR is doing. We've been talking various perspectives of that, but from your perspective, that how do we strengthen AMR surveillance in hospitals, and how can we really bridge that gap between the AMR surveillance and the antibiotic policy development? What are the nuances there, ma'am? Over to you.
Thanks so much, Nadine. I don't have to tell this audience that surveillance really is the basic, provides a basic for taking action, because it's then that you can report to your regional and your national level, and action can be taken at a global level. Now, surveillance can be population sentinel or basically lab or hospital based. Now, in the lab, we need to be we collect, analyze, and report data, but we need to be appraised of the fact that it tends to be biased, especially labs that are tertiary care centers are slightly at a higher level than most. So the patients you get and the antibiotics you use are definitely high-end antibiotics. So it's biased with a higher prevalence towards resistance. And that's one point. And the second is, I think the quality of the lab needs to be assessed when you push out AMR data. The lab must be accredited, because when you address gaps, you find that the lab may be doing a lot of stuff, but the accreditation, the attention to detail, and the external quality assurance is imperative. It's really one of the basics on which you assess your AMR surveillance data. And thirdly, and I think I'd like to thank ICMR for this, at least because we're part of the network, it's allowed us to report back our data to them so that that can be part of the national level data. And for that, they've got a really nice LIS system. We have the LIS, but we managed to connect it with theirs. And so you decrease workload, you decrease your errors, and you share the data. I mean, what's the point of just us sitting with our data in our little niche area and saying, oh, wow, this is it. But it has to be shared for our country so that decisions can be taken across the board. Now, one size does not fit all. Really remember that. And nothing is a better example of that than our country. But the challenge is how you link AMR surveillance with antibiotic policy. We've been doing antibiotic policy and having our little antibiograms for years. And every time we spoke to our clinicians, they'd say, we're listening to it, we'd audit it, and we'd grumble with them, and then we'd say, they'd say, not correlating. So finally, we decided to not only look at site-wise, urine, blood, respiratory, surgical site rates as surveillance. We stratified it, one, based on patient's site, whether he was going to be admitted in the hospital ward or in the hospital ICU. We further stratified it whether the patient was coming from the community or whether it was a hospital-acquired infection. And on top of it, we risk stratified it. That means on the patient's risk, whether he had been in hospitalization for 30 days, had been on antibiotics, previous antibiotics, whether he had any comorbidities, and whether he had any invasive devices. Finally, we got a policy. It's 9 per site. And I'd like to thank ICMR, because it was only because we could actually ring up every single patient who was on an antibiotic and ask him a detailed history. If the patient was discharged, we'd call them at home and say, were you on antibiotic? Were you hospitalized before this? Because the data that we suddenly started making sense. For example, in a community-acquired pneumonia, in a patient who came to our hospital, we finally found that strep pneumonia was the #1 pathogen. No longer was it Klebsiella or funny resistant bugs, because the patient had already been on an antibiotic, and that was not taken into criteria when we made our policy. Finally, we found that a patient coming in with a bloodstream infection was Salmonella typhi if he was from the community. And if he came to, in fact, even if he came from the community and was sick enough with the perforation, we still got Salmonella typhi, because we stratified him with so many factors in place that we had. So now they believe in it. They're actually looking at the little book we churn out, because the data has been stratified, and that the policy for empiric therapy means so much more than it did before. I mean, I'm guilty of actually churning out rubbish data, I call it now, because it was lumping data. And that's what, if your empiric policy is going to be based on lumped antibiotic surveillance data, your clinicians are not going to buy it. So you must, it's a very, very painstaking, I don't understand why people are not doing it earlier. It took us a long time, but now we've started doing it far more, and our next year's is against better data than before.
Thank you so much, ma'am, for your response. And since we have been talking about data and your practice, that the work that you've done, I would like to bring in Dr. Sonali. First of all, thank you so much, Dr. Sonali, for being here and being patient as I loop you in to talk now. We've just heard so many perspectives here, and this is the diversity of people or the stakeholders or the ecosystem that we really need to resolve the problem at hand of AMR and the growing, the global health crisis that is becoming slowly. From your perspective, we've heard all of our stakeholders and experts today. Pfizer has also, is closely and very, deeply working in the space of surveillance and AMS. And we know about, your program Atlas. So if you could, talk in more detail about it, and from, like, we heard data as well. So if you could just show us, throw more light that how Atlas is also supporting institutes with data and your response in that.
Great, thank you, Dr. Nalini. It has been extremely exciting and educational, I would say, to hear to all the panelists today. Coming to Atlas, the full form being Antimicrobial Testing, Leadership and Surveillance. I hope I'm audible and visible. I suddenly don't see the screen for some reason.
Yeah, we can hear you.
Yeah. Yes, Dr. Sonali, please go ahead.
So, Antimicrobial Testing, Leadership and Surveillance. So this Atlas program, we started globally actually many years back, about around in 2004. So the data of the surveillance of different antibiotics has been available for last many years, at least more than 15 years. And it's available from, or this program is ongoing in 76 countries as of now. We also, in India, we have about 10 sites. What it actually gives is a longitudinal, I would say, a continuous data of surveillance of different antibiotics, not just aggregated, but also from your own, local epidemiology perspective, based on which the hospital, the doctor could decide his own antimicrobial stewardship, kind of a program or antimicrobial protocol based on that data. A number of publications have come out of it. I'm told more than 80 publications have come out of this data from different parts of the world. And we are really looking at this data being constantly adding to be able to see the difference in the sensitivity patterns over the years. It also gives us good understanding of where are we going from AMR perspective. So this is quickly about Atlas. All the doctors, any doctor can get access to this data. That's the beauty of it. You don't necessarily have to be part of that, but you can still get an access and get an understanding of the antimicrobial sensitivity in your area or around in your country if required. Dr. Nalini.
Yeah, I just unmute myself. Thank you. So thank you so much, for giving your inputs, and maybe like we would be, while we are, we have positive time and we would be moving towards closing remarks. But I just wanted to understand from you that you represent a very different set of stakeholder group, which is the industry, and the role of industry in curbing this particular challenge, and for that matter, any global health challenge that we have becomes very pertinent. From your perspective, what are the specific actions, specifically that the industry can also take, maybe at the national, specifically, in the national context that we are talking about here.
Right, thank you. And I was listening to Dr. Atul Goyal as well, that I think it's the responsibility as a part of healthcare system. It's a responsibility of all of us, everyone in the larger spectrum of the healthcare system, to be aware about antimicrobial resistance that's developing. So as pharma, of course, there is a keen awareness in Pfizer that you would have heard different programs that we have been doing. I think at the community level, clearly the awareness, education of the community is important. At the healthcare professional level, the educational program, and it's not just the doctors, right? It's more also about the nurses, the paramedics, the pharmacists, and the better the open kind of programs that now we have for nurses. Those interactive programs are something that the industry has been working on. One of it is also about capability building, and that's where infectious disease fellowships come up, so as to be to have more ID specialists who can then also train more doctors, or also work with different doctors from the antimicrobial stewardship perspective. Of course, a surveillance program is always helpful. And I've kept R&D last, because that's I would think a new antibiotic or a new anti-infective coming up would be that dependency we could keep as a much lesser dependency. I think it's more about protecting our current anti-infectives, and that's what all of us as a team have to work towards.
Absolutely. I think I couldn't agree more with you, Dr. Sonali. And I think we've heard from multiple perspectives. We have heard today, the gravity of the problem, but at the same time, we have heard how different stakeholders are working in their capacity from their own specialization to curb the common problem that we have. And I think that is absolutely commendable, first of all. And with that thought, I would like to, come back to all of you for a closing remark, since we have a bit of paucity of time. But I think it's really pertinent to have a closing remark, first of all, from all of you. And, what are your thoughts that, how all of you think that, maybe in future, more collaborative approach can also be helpful. So Dr. Subramanian, we'll just start from you.
Sure. I think we've done a lot of good work, but the mountain still remains to be climbed. 80% of the antimicrobial use is in the agricultural university, in the agricultural sector, non-human sector. And in the human sector, 80% of it is outpatient in the smaller clinics and things like that. Those are the areas that we really need to start working on, and that's far more challenging. At least in a hospital as a more organized area. And even here, I think a lot of points have been beautifully made. The role of clinical pharmacists, the role of nurses, let's not forget that. A lot of different stakeholders can be pulled into it. I think there's a lot of work to be done. And I'm happy that we are doing things now. At least we've acknowledged it. A lot of systems have been put in place, and a lot of training needs to go into it. And we also need to have feedback measures. And like how Dr. Kamala pointed out, we need interactive systems where we can interact in real time. And the data needs to be something which makes sense to the stakeholders. Otherwise, it's just a pie in the sky. So I think a lot of things are happening, but we need to move a lot faster. And I'm confident we will get there. I mean, we are probably one of the smartest people around, as a community. So I think we should leverage the smartness that we have, especially with computers and AI. A lot of technology that we have. Let's start pulling all that, brains that we have, and look at how we can put this into fast forward.
Absolutely. Thank you so much, Dr. Subramaniam. Dr. Sajid, over to you for your closing remarks.
Yeah, thank you very much. I think it's very important. I mean, we are in a crucial situation now where it's on the radar of the global world. It's on the radar of India. And we need to ensure that our policymakers truly understand the significance of what we're dealing with here, what we're discussing today, because they have multiple crises at all points. Any leaders will have that. But we need to make them truly understand the seriousness of the crisis that the globe is facing with AMR. And as an example, of course, what we went through in COVID, but in a much longer, drawn out, and even more serious situation. The second thing is, I think we need to be very, we should not discard the importance of data and evidence generation. Without that, it's very difficult to even know whether a particular intervention is successful, whether what we're doing is working, and most importantly, to have to be able to get financing and funding and get policymakers to believe in it. So that's very important. And last but not the least, I think there has to be a movement. We are working in silos to a certain extent. We're all doing our best, but there has to be a way in which we can get a movement going within this country and all other countries, actually, where we realize that this is part of our DNA, that we have to do something about it. Otherwise, it will overtake us, and it is overtaking us. So before that happens, let's ride on the crest of the wave rather than behind the wave. Thank you very much.
Right, sir. And I think I couldn't agree more with you. And Dr. Kamini, the closing remarks right now are in the line of the need of data and a collaborative approach. So I think you're at the center of all of these things. So closing remarks from you.
I think Dr. Sujit very rightly pointed out the importance of evidence generation. That would remain our priority in years to come. And also, how we can utilize the genomics, the next generation sequencing, to kind of identify how the transmission happens. One Health is an important concept for AMR, but how much of drug resistance that we see in our patients is actually contributed by how much antibiotic we use in the veterinary or the agriculture sector. So there are a lot of questions that need to be answered. But one thing that we know is that our health system is very, very heterogeneous. One size is not going to fit all. We need, customized training programs for all levels of healthcare. And that Icmr obviously cannot do alone. Everyone needs to pitch in and support and collaborate with Icmr so that we are able to move in the right direction. Thank you.
Right, absolutely. Thank you, ma'am. Dr. Camilla, over to you.
I think one closing point is that physicians are clearly seized of the problem of side effects of antibiotics in the terms of cost, in the terms of C. diff infection, in the terms of maybe some rare side effects, but they're not seized of collateral damage. Somehow we've got to get that to them to understand, and it doesn't worry them. No, it's okay. The second point is that I think we need to define, just like we defined 5 moments of hand hygiene, our antibiotic bundle needs to be 4 moments consist of 4 moments. The first one would be decide when an antibiotic is needed, depending on the seriousness of infection. You've got to give it straight away. The second moment would be send cultures. I mean, I hate to keep reiterating because I'm a microbiologist, but I think send cultures, start empiric therapy, source control. The third moment is stop if you can. I mean, nothing is better than stopping an antibiotic. Narrow it down and switch from IV to oral. And the fourth is duration. I mean, there are enough guidelines today that depending on the bug and the seriousness of infection, your duration is actually clearly defined today. I mean, just for good measure, don't continue.
Right. Thank you so much, ma'am. Dr. Grace, over to you. I'm so sorry, you're on mute. Could you please unmute yourself?
Sorry. So thank you for that. First of all, I would like to thank this panel for having a representation from our community, because as you know, in India, I belong to the second batch of clinical pharmacists in India. But the problem, what we have when it comes to our community is that in the central domain, when it comes to the government domain, I had the chance to interact with a lot of government doctors, but they are saying they don't have any support system. Like there is no, the clinical pharmacy is non-existent when it comes to the government sectors, except for the research projects. So that is something that we would like to bring to the attention of all the panelists and all the policy makers, that we need a sea of change. We need a sea of change to steer, like what Dr. Sujit was saying. We need a movement. So for all that, we need capacity building, and towards that, we should have this multidisciplinary approach in addressing this top 10 global threat that we are facing in our times. So thank you.
Thank you so much, Grace. Dr. Grace, I think it was really important to hear that, and I think it's great that you highlighted that particular aspect. We have so many other stakeholders listening to you, and we can just hope for more constructive solutions in the future. And like Dr. Sujit was also saying, that not working in silos is really imperative right now. So I think that would be a way forward. And last but not the least, to another most important speakers that we have today, one from the global health perspective, one industry voice. Dr. Tim, before we move to Dr. Sonali, I think it will be great if we can hear the closing remarks from you.
Thank you very much. And really, I just want to echo what all of the speakers before me have said here. Very important that we achieve sustained commitment across society to address this problem. And that means not only in the professional healthcare sector or in the world of R&D, but beyond. We need a full society commitment to address this problem. So that does mean there has to be more of a movement, so that there is buy-in and actually a mandate to really pursue the change that's necessary here. We do need to increase the cooperation and collaboration we do, not only amongst the crowd that we are here, but into other stakeholder groups that are touched on or actually impact on AMR as a threat to human health. We also, though, need to make sure that we don't let the complexity of the situation create a smoke screen that prevents progress. There are a lot of solutions that we know will have impact, and let's make sure that those solutions are put into place and we start making the progress that can be made today. It's not going to be solvable next year or 5 years or 10 years down the road, but there's a lot we can do today that will help improve healthcare, people's outcomes in treatments, and indeed save lives. And let's get on with doing those things that we know are doable today and climb that mountain so that eventually we can reach the top and control AMR. Thank you.
Thank you so much, Dr. Tim. Dr. Sonali, over to you.
I think the only, I would say, from my side, with the COVID pandemic, there is a lot of awareness in the community about health, and riding on that awareness, I think, everyone from the healthcare system should come together. There could be more public-private partnerships for improving the community awareness as well as the awareness at the healthcare practitioners level. Unlike some other diseases here, the community awareness is going to be extremely important as well, because it is everyone who has to work towards it. Only then this whole issue of AMR can be tackled. And again, with COVID-19 pandemic, we have learned that now we don't look at just a country, but we actually look at the whole world as something that we have to work together as a world. And I think even for AMR, we need to work together as a community, as a world.
Right. Thank you so much, Dr. Sonali. And I think with this, while we come to the close of our panel too as well, but the presence of all of you, the experts, the subject experts, the speakers, that we have today, I think this is the best of our country, and all of you in your own individual capacity are working so closely and so deeply in this area. And I think your presence today definitely shows that how all of you are, first of all, committed to the cause, and how all of you are also committed to working together. So this is really commendable, and we just hope that this commitment retains more sustained in the near future, and more greater partnerships come out of this. Thank you so much. And now I will like to invite Dr. Sonali for the vote of thanks for our entire panel and experts today. Thank you so much. Over to you, Dr. Sonali.
Thank you, Dr. Nalini. Thank you for an excellent presentation today. I would like to start by thanking all the panelists today. I think in the last 2.5 hours, the amount of thought leadership that has I would say suggestions, ideas that have come up in the last 2.5 hours has been absolutely excellent. Thank you so much for that. I would specifically like to thank our guests today, Dr. Atul Goel and Srimati Shailaja Teacher. And thank you, Icmr, for the opportunity for the partnership on this extremely important topic, which is close to our heart as well. Thanks to our partners, Americares, and obviously IHW. I do hope that this is a start, this open platform is a start of this, a larger level educational initiative where we can involve every person in the system to understand the IPC and AMS better, and hence overall improve our healthcare system towards fighting the antimicrobial resistance. Thank you very much.
Thank you so much, Dr. Sonali. And with this, we come to the closure, and I would like Anisha to take over from here. Over to you, Anisha.
Thank you, Dr. Nalini, for conducting this discussion. Very insightful and lots of good ideas coming in from our experts who joined us today. Now, I would like to take this opportunity to invite Mr. Sharat Goswami, Senior Director, Emerging Markets, Policy and Public Affairs, Pfizer India, to give his closing remarks.
Without taking much time from everyone, I want to thank all the participants. Thank you for your views. Thank you for your interest in the subject. Most of all, thank you for all the work and all the effort that you're doing in this direction. Please continue to guide us, to advise us. We'll keep coming back to you as we roll out this initiative of Open AMR that we have launched today. To the extent that you can, given that you are practicing clinicians, please encourage your own staff, nursing staff, paramedical staff, as many people as possible to participate in this program, to register, to get themselves certified on IPC practices as we have designed in this program. And we will keep coming back to you with the progress that we are making. With that, thank you for your time, and back to you, the organizers.
Thank you, Mr. Goswami, for giving us your closing remarks. This brings us to the end of today's summit. On behalf of IL Chapter Council, I would like to thank all experts who have joined us today to talk about antimicrobial resistance, healthcare-associated infections, and infection prevention and control. Special thanks to Pfizer India and Americares Foundation of India for supporting this cause. Greater awareness and better education for healthcare practitioners will go a long way in preventing harm to patients, healthcare workers, and visitors due to infection in healthcare facilities, which are fundamental to achieve quality care, patient safety, and health security. From everybody at ICW Council, goodbye and have a great day.